counselor at Boxer-Wackler Vision Institute. I've worked with Dr. Boxer-Wackler for a little over a decade now, hard to believe. And I'm also the optometric liaison, so a lot of the optometrists that see patients, it may actually be the initial person to diagnose you. I will go out and update and educate some of the doctors that aren't as familiar with these treatments. So it's very, very important that they know how to tell you, not just that you are diagnosed with the condition, but at least they know how to treat it. In the past, the old treatments were to do a cornea transplant. I'm sure you know a little bit about that, and it's very highly invasive, a little bit scary. So we're actually going to talk about a lot of the treatments today that are going to help you and are less invasive, not as scary. I'm going to show you the itinerary for today. In just a little bit, we're going to start with a TEDx talk that Dr. Brian did. I'm not sure if you're familiar with TED Talks, but this is going to be Dr. Brian teaching people about how he conquered keratoconus and fought for people with keratoconus to be able to develop treatments and be innovative where other people were critical. Of course, a lot of innovators have that problem. You're always going to be criticized. But Dr. Brian has been just amazing in helping patients with this condition, really being there for them and helping them change their lives. At 9:40, Dr. Brian, as we call him, will talk about modern keratoconus treatments. At 10 a.m., we'll have a Q&A, and 10:45, a mini coffee break. 11 a.m., we're going to have Professor and Dr. Christina Kenny. She's going to talk about the causes of keratoconus. She actually does a lot of clinical research, very scientific research on the causes for keratoconus. And then at 12, we will have lunch. Oopsie. All right, and then at 1:30, life-changing discovery. We have a very special guest today. You may know him as the Olympian. He's a gold medal Olympic that actually has keratoconus too, and he had treatments by Dr. Boxer-Wackler. So he's going to give his story. 1:55 Q&A. 2:15, we have one of our contact lens technicians at the office. You'll love her. Her name is Monica. At 2:30, we'll have another Q&A. 2:50, water break. 3:10, Dr. Brian is going to speak again, and he's actually going to tell you guys the differences between the different types of cross-linking. At 3:30, we'll have another Q&A. So we'll start in just a moment. Thank you so much again for coming, especially you just arriving. All right, I'm going to play a little video for you.
Let's go back to one night 2007. I open the door to my house and I see my twin daughters smiling and greeting me with "Dada, Dada." As I bend down to hug them, I'm fighting back tears. What I'd just been through before I came home, it's almost too much for me to handle. You see, I had just given the biggest scientific talk of my life in front of 500 plus doctors, eye surgeons, just like me. I had a breakthrough procedure that had a 99% success rate and often rendered an invasive, risky surgery unnecessary. Naively, perhaps, I expected a standing ovation, like you see in the movies. Instead, I heard whispers and a few half-hearted claps. I was confused and deflated. In the coming days and years, I would be skinned alive by many other eye surgeons because I rocked the boat. That's me as a kid. I wore glasses and soon had the bullies calling me Four Eyes, and you can see why. My mom and dad advised me of that ancient Chinese proverb about sticks and stones may break your bones, but names will never harm you. Okay, it's not a Chinese proverb, but I'm sure it's been around long enough to be one. And they also advised me that if any bully got physical with me, then I had the right to defend myself. But I never thought that years later, as a doctor, I'd still be fighting bullies to save my own professional reputation as I was saving patients' eyesight. Keratoconus is a degenerative disease of the cornea, which is the outer lens or windshield of the eye, and it bulges out uncontrollably due to weakened collagen fibers. So it's like having a hernia in your groin, but it's in your eye. It occurs in 1 in 500 people, and that's a 400% increase than in the past. So a number of you watching have keratoconus, or don't yet know you have it. It's caused a tremendous amount of distortions in vision, such as multiple images and severe glare and halos at night that can make night driving impossible. It can rob people of the ability to lead a normal life. 12 years ago, the traditional treatments for keratoconus were 1, hard contact lenses that could feel like shards of glass in your eye, or 2, an invasive and painful cornea transplant from a cadaver that could take 6 to 12 months to recover from and has some serious risks, including blindness. Based on the work of Professor Theo Seiler in Germany, my team and I developed a breakthrough procedure. We called it C3R, which stands for cornea collagen cross-linking with riboflavin. It's a 30-minute outpatient procedure that uses special vitamin applications combined with a special type of light that strengthens the cornea and stops keratoconus from progressing. And best of all, it's just a one-day recovery. One-day recovery. So for the first time in history, we could non-invasively prevent people from having cornea transplants. It was a breakthrough. Now I want to tell you a story about my first C3R patient. He's a very famous Hollywood movie producer, and you've all heard of his films and the stars who were in them. And he was losing vision from keratoconus. I had at the time figured out C3R, but I had not performed it on anybody yet. So I had the very open discussion with him and told him that he would be the first. And in the end, he trusted me and gave me the thumbs up and said, let's do it. So I performed the procedure and everything went perfectly. I was so excited. I felt like running all over the streets of Los Angeles, just shouting about what we had done. Thankfully, I restrained myself. Because in the past, what had been increasing amounts of cornea steepening and increasing astigmatism was now this flat line of stability, and that's why I was so excited. But I knew we needed more treatments for the medical community to accept C3R. So I continued to treat patients. Eventually, I submitted a paper with our results to a major ophthalmology symposium, and it was accepted. I delivered my talk in front of 500 plus eye surgeons, and it went great. I was elated. But instead of a standing ovation, it was mostly silence that I heard. It sucked all the joy right out of me, just like a balloon being deflated. And even worse, worse, when I got off the podium, I had doctors coming right up to my face saying, "There's no way you can stop keratoconus from progressing," or "I don't believe your data," or "Brian, you should just keep doing cornea transplants. There's nothing wrong with them." That was painful. At the next meeting I presented at, there was a similar reaction. And soon I realized this was no fluke. This was the pattern. But I refused to give up. I believed in myself and my procedure. Then these doctors started spreading lies, saying C3R doesn't work. It's a gimmick. They also spread the lie that C3R was illegal and that I should be put in jail. And they were spreading this to doctors nationwide and to patients, trying to discourage them from flying in to have C3R. I was completely shocked. This was the last thing in the world that I thought would happen. Well, the medical establishment, I realized, was trying to crush and destroy me and C3R. They prompted investigations by ophthalmology and regulatory organizations. And even though I was cleared of any wrongdoing, that didn't stop the lynch mob. I felt massively stressed on a daily basis. Over my career, I had published 49 articles in peer-reviewed medical journals. I had delivered 244 talks at scientific meetings, but now overnight, I wasn't being invited to speak anymore. The phone stopped ringing to be interviewed by the trade journals. I felt alone and totally abandoned by the field that I had given so much to over my 20-year career. I felt like I was living two alternate realities. During the week, I was seeing patients with these amazing results, but then at weekend conferences, I didn't know if a doctor was going to come up to me and congratulate me, or spit on me, or take a swing at me. You hear about conspiracy theories? Well, I'm here to tell you, this is true. One night, things got so bad, I didn't think I could take it anymore. The stress of my inner struggle was just tearing me apart. And I spoke to my wife, Selena, about the solution: giving up C3R. I knew if I did, I could go back to that safe, comfortable practice that I had before C3R, and I would be back in the club again. But on the other hand, I saw C3R was saving patients from cornea transplants. It was hugely successful. Selena and I talked for many hours into the middle of the night, and we finally decided that if I would sacrifice my professional reputation in the name of helping patients, I would accept that trade-off because I became a doctor to heal. So I put on earmuffs and I forged ahead with C3R because I refused to give up. I believed in myself and my procedure. And this reminds me of this famous poem by Robert Frost. When I came to the fork in the road, I chose the path less traveled because I believed in myself, I believed in our results, and it was the right thing to do for patients. But still, I had taken a risk, and now I was being forced to pay a price. And I just didn't get it. The procedure had a 99.3% success rate, yet I'm being constantly attacked. Then it finally hit me like lightning. C3R was directly threatening the incomes of those eye surgeons who were performing cornea transplants for keratoconus. Then you add professional jealousy into the mix. It was really clear what was going on. But this realization saddened me, because doctors are always supposed to be advocates for their patients. That's the Hippocratic Oath. I never thought that I would be attacked and ostracized because I put patients first. Well, little did I know, though, something big was about to happen. One day, a big guy with a big secret walked into my office. He's 5'10", built like a battleship, strong as 10 oxen, and as nice as a good neighbor. His name, Stephen Holcomb. And in 2007, he was the United States' best hope for winning an Olympic gold medal in the sport of bobsled because he was the top driver. But he was keeping a secret from his coaches and his teammates. He was losing his vision from keratoconus. And it got so bad that he had to drive the bobsled by feel because he could no longer see the track. Now, I'm not sure how much you know about the sport of bobsled, but it's an extremely dangerous sport. Just imagine flying down the icy, windy bobsled track over 90 miles an hour, holding on to virtually 2 shoestrings to steer the monster 500-pound beast of a sled. Athletes have been paralyzed or died because the driver lost control going around a turn, flipping the sled. It's dangerous with perfect eyesight, let alone having profound vision loss. Stephen realized that he had to tell his coaches, and he did, and his teammates, about his keratoconus, how he lost most of his vision, and that he had to retire. But his coaches and the U.S. Olympic Committee wanted to find a solution. So they sent him to 12 other eye doctors all around the country, but they all gave him the same bad news. You need a cornea transplant. Because of the fragile nature and the lengthy recovery, either way, he would have been out of the sport. But then his medical team doctor found this one doctor out in Beverly Hills who was doing something different for keratoconus. That's when I met Stephen. I performed the C3R procedure and then followed it up with implantable lenses to improve his vision. And then it was like a miracle. He was 20/20. He immediately started sledding again, and then in 2009, he won the World Bobsled Championships, the first for the United States in 50 years. When gas was 25 cents a gallon. Then in 2010 at the Winter Olympics in Vancouver, Stephen won Olympic gold, the first for the United States in 62 years. And the last time that happened, Harry Truman was president in 1948. Stephen's historic gold was widely covered in the media and sent a 9.0 Richter scale shockwave throughout the medical community. And it got word to patients that there's a better option than waiting for a cornea transplant with its uncertain outcome and lengthy recovery. And it also pierced the vocal cords of many of my critics, because essentially now there was an Olympic gold medal behind the C3R procedure. Stephen and I appeared on Dr. Phil's The Doctors daytime TV show, where I announced the name change from C3R to Holcomb C3R to honor Stephen. And it was the first time that a procedure was named after an Olympic athlete. At the National Vision Awards, Stephen and I were honored for our courage and perseverance. At the 2014 Winter Olympics in Sochi, Russia, Stephen won double bronze, making him the most celebrated bobsled driver in U.S. history. Stephen wrote a book about his journey and sent me enlarged, framed artwork that hangs beside my desk. He inscribed this message: "No words can explain. You saved my life. Thank you." Well, I don't know about that, but I do know that Stephen saved my professional reputation. And he gave and continues to give hope to millions of people worldwide with keratoconus. Among those is 7th grader Jake Anstedt from Arizona, who became a straight-A student and helped his basketball team win the championship after we treated his keratoconus. And Monique Cromis from Texas, who had lost the ability to drive her children at night because of severe glare and halos around lights. But now, after treatment, she can drive them daytime and nighttime. And Mariah Bryant from Massachusetts, who tried to join the Army to serve our country, but was denied because of her keratoconus. Now, after being treated, she's on her way to becoming a nurse to help others. Jake, Monique, and Mariah all have their lives back because of Holcomb C3R, which was combined with insertable implants called Intacs. This is my life dream, to help people. The procedure has a 99.3% success rate, and we had performed over 750 procedures before we met Stephen Holcomb. But it was the media attention of Stephen going from severe vision loss to Olympic gold medalist that catapulted the procedure in the public consciousness, even though it had already been scientifically proven. 12 years later, we have performed over 5,400 procedures, saving the vision of patients from 49 states, 44 countries, with ages ranging from 9 to 63. Today, Holcomb C3R is a widely accepted procedure. When I look back, for me, it was a fight to achieve legitimacy for my procedure. For my patients, it's a fight to see again. I think my battle is really about refusing to give up and believing in yourself. And that message goes well beyond eye disease. You know the expression, you have to pick your battles. Well, sometimes the battle picks you. And it's your job to fight. Thank you.
Okay, so I've seen that before, that video before, but I actually almost teared up from that. Reason being that not only do I feel his passion and see his passion from the video, but I've experienced it firsthand. Because for those of you just joining us, I'm Jen. I'm the patient counselor. I worked with Dr. Boxer-Wackler for a little over 10 years, and it's actually kind of sad that this is true. We have actually experienced doctors having professional jealousy, which I didn't even know existed. It's very interesting. But again, as I was saying earlier, with innovation, you're always going to have criticism. There always has to be a first, and that first person is always going to be criticized. But if he stopped at the criticism, then these treatments wouldn't exist. So let me check. Oh, thank you. So I want to introduce Dr. Boxer-Wackler. I also want you to know, besides these things up here that I'm going to read in a moment, he's actually very down to earth. A lot of our staff members have worked with him even longer than I have. And people don't go through quickly. You may see a lot of doctors' offices where their staff always changes. And they're not very personable or friendly, but a lot of feedback that we get from our office is that everybody's really nice and friendly, and they make them feel comfortable. And of course, the doctor as well. And he treats our staff so well. That's why I still work there after all this time. He's actually, he cares. He tells us that he appreciates us. He takes us on staff nights and out to dinner or bowling, or recently they did karaoke, and he sings karaoke, which is quite a sight. So Dr. Bryan is actually recognized as the surgeon's surgeon because he's treated many surgeons and all different types of surgeons, from brain surgeons to heart surgeons, other ophthalmologists even. He also is a pioneer for Intacs. If you didn't already know that, he was actually the first in North America to do Intacs for keratoconus. And he has the longest experience of anyone in the world. He's also the inventor of the revolutionary epi-on corneal collagen cross-linking, namely Holcomb C3R, which he's been performing since 2003. So he'll go into more detail about that procedure. He is labeled America's TV eye doctor because he's been on so many different TV shows and news programs to be able to educate patients on keratoconus, namely the Doctor Show, Good Morning America, Ellen, CNN. There's actually a lot more that aren't listed. He actually, before our private practice at Boxer Walkler Vision Institute, was the director at Jules Stein Institute at UCLA. So that is very prestigious school, well-known school at Jules Stein Institute. But in 2003, he moved to Beverly Hills to be able to pursue more of a broad spectrum of procedures and be more innovative and creative in helping patients. He's also been the U.S. FDA investigator for 13 clinical research trials, delivered 273 scientific presentations at medical conferences around the world, educated more than 1,000 doctors on LASIK, Intacs, and insertable lenses. He has quite a curriculum vitae. If you look on our website, he actually has a very lengthy resume. But he has studied at Dartmouth, overseas in Edinburgh University, St. Louis University, did his fellowship, and UCLA locally. So I would like to give him a warm welcome. If you guys can join me, Dr. Bryan Boxer Walkler.
Thank you very much, Jen. Okay, so despite all that technical experience I have, I may not be able to work the PowerPoint. We'll see. It's really been a pleasure and an honor for me to be able to help people in innovative ways that I do, and with the assistance of my awesome staff and my awesome team who've been with me for many, many years. So what I want to do is go through the overview of what the current status is for keratoconus treatments, and then we'll have some time for Q&A afterwards. So as you're going through, start thinking of questions, and we definitely want to make sure we can answer as many questions as we can. And for those of you who are watching live stream, which are many, many hundreds of people, feel free, you can't directly ask questions right now, but feel free to email the staff at info@boxerwalkler.com or call the phone number and they'll be able to answer all your questions too, which they do on a routine basis. So I want to talk a little bit first about me and my family, so people sort of get to know like the person behind, the professional. And I actually grew up in Santa Monica, California. So, Santa Monica is back then was a very low-key community, and that's sort of the way I am, very just, down-to-earth, regular guy. And, but when I met my wife, I was a counselor at summer camp, and so she was a counselor too. And so I sort of knew she was the one back then. We were 18 years old, but it took about a good 6 years for her to recognize that. So I stuck with it, and so Selena, eventually we got married, and we just had our 23rd wedding anniversary, and that was great. I made her a jigsaw puzzle of our wedding picture as the present, so that was really a fun surprise for her. And then eventually we had 2 children. We have twin girls, and they just turned 10 years old. And they've been a lot of fun. I try to really spend as much time as I can outside the office with them, because those of you with children know you have sort of a finite period of time with kids before then they sort of are on their own. And so one of the things I really like to do is with one of them here, let me see if I get the pointer working. Well, this one here, I'm the coach of our basketball team, so that's been a lot of fun too. And I can tell you, it can really try your patience when you're trying to corral a whole bunch of like 9 and 10-year-old girls, you know, but it's been a lot of fun with that too. So I think I'm going to skip over a lot of this. I think Jen just went through a lot of, you know, credentials and information there, but I have spent a lot of time trying to educate colleagues and the public about keratoconus treatments, including 3 books that we've published on keratoconus as well. So let's just dive right in here. So what is keratoconus? Well, keratoconus, the way I like to think of it, it's a hernia, like a hernia in your groin. And that's really what's happening because keratoconus involves a weakening of the cornea, the collagen in the cornea, and it bulges out just like that hernia does. And that's why when you think of like what is keratoconus, if you think of it like a hernia, that'll make a lot more sense to you to understand what's happening. And it can cause a lot of problems, a lot of vision problems, a lot of frustrations, and it can really derail somebody's ability to lead a normal life. And these are just some common things that you might be able to relate to. You know, if your doctor told you the only thing you need to wait for is just a cornea transplant eventually, and just that's going to be what is going to be in your future probably. Many people are afraid of cornea transplants, and rightfully so. Traditionally in my training years and years ago, I was trained in cornea transplants. It's an invasive surgery. It's got some serious risks, including blindness, retina detachments, glaucoma, and one risk that is really very rarely ever shared by surgeons to patients who are being counseled for cornea transplants, it's almost kind of glossed over or just sort of ignored, is that for the rest of your life, if you get hit in the eye, your eye is very susceptible to being rupturing open the transplant, and basically the contents inside the eye coming out like a squished grape. And I've been called to the emergency room where I'm on staff at Cedars-Sinai many times in the middle of the night because a patient who had a cornea transplant got a little bump, and that's exactly what happened. And typically it's going to end up being a blind eye that may even have to be removed. That's one risk that is almost never shared by surgeons about cornea transplants to their patients. But these are some other things. People can feel very hopeless. They can have bad glare and halos at night, even giving up the ability to drive at night because of that. People can get very depressed over this. And if you haven't read Stephen Holcomb's book, he talks about that. He'll be speaking later today in the symposium. So you definitely, you know, if you're watching on live stream, you want to make sure you watch that talk. It's going to be amazing as he really opens the kimono on his experience. People can be concerned about passing the driver's test at the DMV. And then also, a number of people went in for LASIK and found out that they had keratoconus, didn't even know it too. It's not uncommon for doctors to not tell patients about these other procedures. If they don't have expertise, sometimes, as you heard from my TEDx talk, a lot of times a doctor's ego gets in the way, and they may tell patients, which is in the best interest of them, that there's other procedures that are outside of their office. Happens all the time. We see patients who fly in all the time. My doctor never told me about these things. I found out about it on the internet. It's sad, but at least if you're here, you're being educated, so you're going to be up to date more than a lot of doctors out there. And people can feel, you know, that there's no hope, and they're very concerned about it getting worse in the future because it is a progressive disease. So for the many, many patients who are told, you know, just get hard contacts or wait till your vision gets bad enough for cornea transplant, I mean, that's like a dentist telling a patient with a cavity. Imagine your dentist telling you if you have a cavity, well, we're not going to do anything about it. We're just going to wait until it gets so bad that you have to then just get your teeth replaced. I mean, can you imagine your dentist saying that? Of course not. But when eye doctors tell patients that with keratoconus, that's essentially what they're saying. And that just makes absolutely no sense. Does anybody, raise your hand, does anybody feel that makes any sense? Of course not. So because of what we've been doing, really cornea transplants in my practice are a thing of the past because of these procedures that we're going to go into. But we first have to actually look at how do you look at a topography map, which is a map of the cornea. That's really important. So I'm going to go through almost like topography 101 because I'm going to be showing a number of maps in the talks. So the first thing here that we look at, and that usually jumps out, is this red area. So this is a map of the cornea. Red is and yellow is where it's more steep. So it's like bulging out. That's the hernia, if you can imagine that. But the other side of the problem with keratoconus that also gets overlooked and ignored a lot of times, that the blue above is too flat. So if you look at these measurements here, on the scale, okay, going to the warmer colors is steeper, cooler colors is flatter. So for example, in this patient, the pupil is the black circle, and they're looking through steep and flat at the same time. That is what causes the distortion. Regular glasses and regular contacts cannot correct that, okay? That's why you get double vision, halos, multiple images, and loss of vision because of this. And then also, when we look at the K readings, this is actually the numeric value on how steep or flat the cornea is. That's another metric that we look at as well, and astigmatism too. So those are some of the ways to sort of think about looking at a topography map. These are some, I'm going to show you now a whole bunch of different topographies, and we'll go through this kind of quickly. But the steepness and the flatness comes in all these different patterns. Everybody's different. It's almost like a fingerprint. You know, it's unique to each person, which is why when we're planning treatments, we customize it for each person. You cannot take a cookie cutter approach, like one suit fits all, and you can see why here. So here's one pattern of keratoconus. And then here's another pattern, but I wrote KE up here for keratoectasia. So keratoconus can occur after LASIK or PRK, which are vision correction procedures. Many times it can be years afterwards, or it could be soon afterwards. But essentially in my book, it's still keratoconus, even though some doctors call it ectasia, but it's, at the end of the day, it's still keratoconus, and we treat it the same way. But here's another pattern, and here's a different pattern. You can see how the red and yellow is different there. Here it's off to the side, the steepness, and meaning the flatness is over on the other side at an angle too. Here's a more horizontal, but a little tilted with more pattern up there. And this was a patient who had LASIK PRK in the past. Again, here's another example. So it's very different. Again, just think of like, it's like a fingerprint in terms of how unique it is. Very early stage keratoconus will not have the steepness get too much into the center of the vision or center of the map. And that's why in early stages, the vision may still be good, but we can still see some steepening. And for parents who have children with keratoconus, I recommend around age 10, having your children 9 or 10 start being tested, because if there's a little sign of this bulging before they've lost any vision, then they can get stabilized and strengthened before they've actually lost any vision. Now, there's another diagnosis called pellucid marginal degeneration. Some of you may have heard of that, or just known as pellucid. So it's actually still keratoconus. It's just a descriptor of where the bulging is occurring. It's a little more outside. It looks like a crab claw, and that's pellucid, but it's still keratoconus. It's underneath the keratoconus umbrella. It's just a description. So some doctors will make a distinction that they're two different processes, but they're actually, it's still keratoconus at the end of the day. So if you've heard of pellucid, just think, okay, it's still keratoconus. Now there's some basic things, rule number one for everybody, and especially for people with keratoconus, that are important to recognize. Number one is wearing sunglasses, particularly kinds that wrap around, not like the kinds like a Ray-Ban style that just comes straight across, that still lets a lot of light and UV sunlight in. It's the ultraviolet light that's dangerous. It's dangerous to skin collagen, causes skin cancer, aging. We're going to talk about a study that we just had published 2 days ago regarding this, regarding your cars and where you're getting exposed. But if you wear wraparound sunglasses, it really helps block a lot of the UV light from the sides. And then also not to rub the upper eyelids. On the sides or in the corner, rubbing and lower is okay. You're pushing on the bone, but don't rub above, because that friction can cause increase in free radicals. And Dr. Kinney, who's here, is going to talk about the cause of keratoconus afterwards.
But that's based on some of the discoveries that she actually made in her laboratory, and she's going to talk about some of that too. But yeah, don't rub your eyes, especially the upper eyelids. The other areas are okay. So this was a study that was just published in JAMA Ophthalmology just 2 days ago, and it really just got covered and picked up by all the press because it has such potential impact for anybody who drives a car, which is most people. So basically what we found was that we measured the UV protection through windshields and side windows. And by the way, there's lots of dermatology studies that show much more skin cancer on the left side of the face. In North America and in Australia, it's the opposite. They drive on the other side of the road and they have more skin cancer on the right side of the face. So we measured the UV level protection coming from windshields and side windows, and all the windshields had good protection. It's actually mandated by law. But the side windows, the protection was all over the place, and it was much lower on average than the windshields. So that was that study, and basically the take-home message is to look into your car windows, and if you don't know for sure, we actually have, and we have here for everyone who's here, a little card that you can get where you can measure the UV, and if it turns purple or degrees of purple, it means you're getting a lot of UV coming through your windows versus staying relatively white or just very light pink. There's a strip that will measure. You can put behind your window, side window, and the windshield. And if you're just not sure, just have somebody do aftermarket window coating who does, they do window tints usually, but make sure it's a clear film, non-tinted, and it will block most of the UV on the side windows and protect you. Also, there's more cataracts on the left side as well. So how do we treat keratoconus in post-LASIK or PRK ectasia? Well, these are the procedures we're going to cover. Holcomb C3R, which is non-invasive cornea cross-linking, Intax, conductive keratoplasty, CK, and the Visian ICL lens implant. So Holcomb C3R. So first of all, it's a 30-minute, completely non-invasive treatment, and we've been doing this. It was invented back in 2003, and as Jen mentioned, I invented the procedure, and it actually has the longest track record of any type of cross-linking, even the one called CXL, where they scrape off the epithelium. So it's got the longest track record in the world of any type of cross-linking, except in Germany, because there's a group in Germany who developed the invasive CXL procedure. And of course, for epi-on cross-linking, it's the longest follow-up in the world, and I'll give you some examples there. And this just shows, this is the key for any type of cross-linking to work, is you need to get the solution that has riboflavin into the cornea. So here's some examples of completely intact, undisturbed epithelium, but the yellow shows the riboflavin solution in the cornea completely. And there's in a patient who had Intax, and in the sequence, we'll do this right after we do the Intax procedure on the same day. But that shows you the riboflavin in the cornea, and here's a patient just had Holcomb C3R. It shows you the riboflavin in the cornea. So how do we get it into the cornea? Well, we have a proprietary solution that we developed. It took a long time to make this work. And it actually opens up the channels in the skin of the cornea called the epithelium, so it allows the solution to get into the cornea. And that's without scraping or puncturing or doing anything invasive to the epithelium. Now I want to show you what it looks like when the epithelium gets scraped off. There's some kind of instrument typically that's used, and it's just kind of scraped over the cornea. This might make you a little uncomfortable, but my job is to just show you the truth and reality about things. And then this is a video of it actually getting scraped there by a surgeon. So that's the invasive part of the CXL procedure. And that's why we'll go through in my second talk about the risks and side effects of having that done. So the mechanism here for Holcomb C3R, or actually for that matter any type of cross-linking, is that the ultraviolet light reacts with the riboflavin that causes the cross-linking or strengthening, because the cornea is made up of collagen, and then that gives the stiffness and stability. And it also makes the collagen not just more cross-linked, but also the collagen fibers thicker, in fact. And that's been shown as well. There's more cross-linking between those fibers in the cornea. So this is one myth that is sometimes out there, is that C3R, is it allowed to be performed? Well, it's considered an off-label procedure, which is done all the time in medicine. That's how most advances are made, by being off-label. Even aspirin originally, that was used to prevent heart attack and stroke, it was approved as a pain medicine, and then doctors were using it off-label, saying, this is good for stroke prevention and heart attack. So this is no different than anything like that, and doctors are certainly allowed to do that. Holcomb C3R is not experimental. It's been 13 years, stood the test of time, having a 13-year track record at this point, and it's not in a clinical study or clinical trial. And it's just been a normal part of our practice, our daily practice, since 2003. Now, the safety profile is really high. I just talked to you about UV light. Well, we do use some UV light with this, but it's 500 times weaker than the sunlight if you were in the shade. And we measured that with our meter many years ago. So if you've been outside with no sunglasses in the shade for a half an hour, during that half an hour you had 500 times more UV exposure than you get with Holcomb C3R. So it's very dilute. There's been no side effects at all from this UV. Never had any complications, and that's also with some other doctors too who were doing the procedure around the world. It's a one-day recovery, and that's also very typical. Typically no pain, never had an infection, never any scarring or hazing, no cornea denervation or nerve damage, which can happen when you scrape off the epithelium with the CXL, never any cataracts, never any endothelium, which is cells on the back of the cornea issues. So just really, that's what you would expect from a non-invasive procedure. So our indications for using Holcomb C3R are keratoconus, ectasia after LASIK and PRK, which again is keratoconus 2. Patients who had RK or radial keratotomy, they have unstable corneas because of those spoke-like incisions. So we can help with those patients. We can't give 100% stability, but we can slow down the RK patient progression and fluctuations. And we also routinely combine Holcomb C3R with Intacs as well as CK and Visian ICL. And even after PRK, there are some patients where we'll do PRK and then do Holcomb C3R afterwards to strengthen their corneas too. So I'm not going to go over too much of this because Jen talked about it, and Stephen Holcomb is going to be here later and talk about the experience with the Olympics. But after Stephen won the gold medal, that really, like I said, pierced the vocal cords of many of the critics because essentially there was a gold medal behind the procedure. And so when we look at our data, the long-term data, we have an average of 1.3 diopters of cornea flattening. But in my talk in the afternoon about comparing Holcomb C3R to CXL, I'm going to say that that is a misleading statistic. And I'll just leave you with that, and we're going to go through that in the second talk. The real statistic that you need to look at is what's the progression rate of any cross-linking procedure. That tells you really how effective it is. And again, second talk is going to go through that one in the afternoon. So you definitely don't want to miss that, come back for that one. But we have a 0.7% progression rate, less than 1% of people who progress and need a second treatment, which means we have a 99.3% stability rate, and that's just with one treatment. We presented this study many years ago as well at two different big scientific conferences. So here's a case example of Holcomb C3R, pre and post, and then these difference maps. And I like to always look at difference maps because a lot of times this can show what changed. So here's just an example of getting some flattening from the procedure itself. And this wasn't with Intacs. It's not the goal or intent to give cornea flattening, but sometimes we do. And I just think of that as like a little bonus or a cherry on top. Intacs, as we'll talk about, really that's the goal, to give cornea flattening. But sometimes we do with this procedure. Here's another example of getting some flattening. Now here's a patient who was 13 years old when I first treated him, and this was back in 2004. And you can see his different maps going from 2004 here to 2005 to 2011 to 2015, and certainly there is no worsening of his keratoconus. That's the right eye. So this case right here that I'm showing you is certainly one of the longest follow-ups that you'll ever see for any type of cross-linking. And this is, of course, Epi-on Holcomb C3R. And this is longer than any other, physician or center in the United States. Since, as we mentioned, we started this in 2003. Here's the other eye, same thing, 2004, 2005, 2011, 2015. You just look at the measurements, and you also look at the numbers. We're not seeing any steepening now. And so that's just an example of like as long-term as you're probably going to find for cross-linking with, and this is Holcomb C3R here. So very happy, and he was an athlete. He was playing hockey, he was a goalie, and he needed good vision, and his parents were elated that he was able to be helped as well. So this is the opposite of someone who took a wait-and-see approach with keratoconus. This was a 19-year-old student. She was diagnosed in 2003. At the time, she was doing well in soft contact lenses, and we diagnosed her with keratoconus, as you can see. And this is the astigmatism she had, which also is common with keratoconus. The right eye had less than a diopter. It's in pink, 0.75. The left eye had about 2.25, 2.25 diopters, a little higher in the left eye. And that's what her keratoconus looked like. We talked about Holcomb C3R. Unfortunately, she went to another doctor who told her, no, just wait until you need to get a cornea transplant. And so she waited, and then she came back almost in tears a year and a half later, and her keratoconus was just explosive. You can see how much change there was in 1.5 years here, from here to here, and that's all the steepening that occurred. Really dramatic, and her astigmatism went up to 4 diopters in the right eye, and her left eye really exploded. You can see the difference map, and then it's showing how much steepening occurred in that year and a half. 2 diopters of astigmatism up to almost 9. So now we had to add more procedures, Intacs and CK, to get her back on track, when it could have easily been prevented had we just done the Holcomb C3R originally. So the point is, you do not want to take a wait-and-see approach with keratoconus. It doesn't make any sense. There's just no logical rationale to do that, especially when we have something that's totally non-invasive with a 1-day recovery. So parents, of course, also, children that are newly diagnosed, you do not want to wait, because keratoconus is even more aggressive with children. So, and that's why when we do the customization of our cross-linking amounts, children need the highest amount because we know they're more aggressive. Also, people who had LASIK or PRK that developed keratoconus, they also need more cross-linking than the average person because of the previous flap and laser treatment. They need more strengthening. But we do customize it actually for every person, the amount of cross-linking that we do. So let's talk about Intacs next, because this is used very often with Holcomb C3R when we have to try to improve the vision. So Intacs is considered, think of Intacs as like a vision correction or vision aiding improving procedure. So they're tiny little segments. You can see that's on my finger there. And this is showing it actually in the cornea. And we usually use one segment like shown, but as you saw where those maps were, how the steepening was sort of variable from person to person, we customize where we put the Intacs and also the thickness of the Intacs. So it has to be placed just in the right way to get the effect that we want. And the nice thing about Intacs, it's typically a 7-minute procedure. They're underneath the surface of the cornea, so even if people don't like wearing contact lenses or they feel their contacts and they're uncomfortable, you really typically never feel the Intacs because it's underneath the surface. Sort of like putting a pencil, in a book. The top of the book cover is still there, but the pencil is in between, way deep down. Intacs is very similar. And by the way, I've done Intacs on my brother-in-law and sister-in-law probably, I think, 13 years ago now, and they still talk to me at family functions, so everything's good with them. So certainly if it's good enough for my family, it's good enough for everyone else, and that's always the way I am with any procedures that we do. Yeah, so usually 7-minute procedure. Also, you can use the same analogy. You don't feel the Intacs, kind of like a dental filling. Who here has had a cavity taken care of? Yeah, pretty much. Sometimes people like are like, no, I never had a cavity. Like adults, I'm like, wow, you must have like bulletproof teeth. These are the people who can pull the train, you know, with the rope. The teeth are so strong, I think. So in any case, like if you've had a filling for a cavity, you don't feel it. Even if you have technically a little implant in your tooth, the Intacs is pretty much like that too. And the material doesn't break down or degrade. It's made of the same material that the original cataract lens implants have been made out of, which has, you know, stood the test of time for I don't know how many decades, 40, 50 years. So the material is very inert. It will not react and doesn't break down. And the key is that it causes flattening. That's really why we use Intacs, because we put them where we need to get the flattening over the steep spot. So in the early days, we were using 2 segments. So an upper and a lower segment, and it caused flattening over the whole cornea. And we definitely had some patients who improved with that technique. We had some patients who didn't do as well and actually may have gotten a little bit worse from the double segment technique. So and that we first started back in 1999, and we did publish a paper back then, my how time flies, that was back in 2003, which was the biggest study of the time for Intacs for keratoconus. And then we started to think about, well, if we look really at the cornea, like I just showed you, half of it is steep, and what's this half up here? Flat. So then I started to realize, there was one patient I started to think about, like, well, if we're flat up here, why do we need an Intact up above? We don't. So then we started working with just putting one segment in, because it just targets this area. And we definitely don't want to make the blue flatter. If anything, we want to lift it up. So then we made this discovery that one segment is actually better than 2. Usually it's like the more the merrier, not with Intacs in keratoconus. So as it turns out, when you use one segment, you push down, but the upper part can push up a little bit where it's flat. So we get a little bit of what I call the beanbag effect. And most of the time, 97% of patients, plus or minus, we're using one segment because that's their pattern of keratoconus. And 2 segments is only maybe about 3% of people when they have more central keratoconus. So here's an example of the beanbag effect. So there's the before and the after, and it shows flattening. The red isn't as big. But again, when you look at the difference map, you can really see what changed. It's almost like the injection mold, you know, what happened. When you subtract before and after, this blue shows the flattening from the Intacs. But look up here, it caused the upper part to pop up a little bit. So it got a little bit steeper in the flat area, which is exactly what we want. So that's why we use the one segment. It's that beanbag effect there. And that, in this case, is where the Intacs were placed. And here's another example showing where the Intacs were placed in pink. As you saw, they're clear, but just showing it pink here, and showing the flattening and some of the little elevation up above. So you do get a little bit of that beanbag effect there, and it's very, very consistent. Well, I wanted to do a study and compare single versus double segments, and we did a matched group, and we published that, and we found that, again, you get better improvements in single segments. So we then developed a technique for doing this to really maximize the results. We've been using that now for over 10 years. But there certainly can be problems with Intacs. We get a number of patients who come in from different parts of the country who've had Intacs who say, you know what, it didn't work out for me. I'm actually worse. And so we look at this, and it turns out that these are people, typically they had 2 segments placed. And not only were there 2 segments placed, but some of the surgeons put a thicker segment in the flatter area and a thinner down here. And the thickness of the segment corresponds to how much flattening you get. So the thicker segment, the more flattening. So to you all, does it make any sense to put a thicker segment in a flat area? We just talked about it doesn't even make sense in this case to put a segment there at all, let alone the more flattening a segment. So these are why people can have problems after Intacs. Basically, Intacs surgery, it's a surgery, and it's just like a mechanic who has to rebuild a car engine. If it's not done just the right way, or you put the carburetor where some other parts are supposed to be, it's not going to work well. This is sort of similar. It's got to be done properly to get the results. So we actually published about that too, reduced vision from inserting 2 segments, especially in that order as well. So yeah, this is almost like the old video, videos like, Intact's Gone Wild, a play on that one. And a lot of times for those patients, the story is, well, my insurance covered it, so I just went to my local surgeon, but they ended up regretting it. So in the end, a lot of people feel that certainly wasn't worth it. So, but we can fix it though. The good news is we can take out the segment, and if the lower segment wasn't placed right, we can remove it, exchange it for a different segment. So I mean, the nice thing about Intacts is they're removable, they're exchangeable, so we can repair what didn't happen the way it was supposed to happen, and that's at least the good news. Now we do find we get the best results when we combine Holcomb C3R with the Intacts. And so we do that on the same day. And it's still about a 1-day recovery for patients typically when we do that as well. And here's an example of where the Intact's placed. And we also then did Holcomb C3R, and we get a nice flattening here. And in this patient, it almost looks a little bit like a symmetrical cornea now. So the results are always going to depend on where someone starts at their stage of keratoconus. So it's really important, my job, not only doing what I do technically, is also when I'm sitting down with somebody face to face and reviewing their test results, I have to explain based on their keratoconus what are your expectations. These are your expectations from the procedures, because where somebody starts with it being mild keratoconus or moderate stage or advanced, that definitely affects what the expectations are afterwards. And setting realistic expectations for me is really, really important, because we want to have people expect what to receive afterwards and not be unrealistic. Here's another example of before and after. And again, here's an example of somebody whose keratoconus was, they were still correctable to 20/25, even though they had a lot of distortions with the steepening, problems at nighttime, doubling and shadowing, despite what the chart showed. So a lot of times the chart doesn't even reflect what's in real life. Because you would think, wow, with lenses they're 20/25, that's pretty good. But if that's a 20/25, you might be able to relate to this, if the letters are smeared, doubling, shadowing, it's not a really good quality 20/25. And it's because of that steepening and that flattening. So here with Intacts and Holcomb C3R, we get a lot of improvement, a lot of flattening. Now this patient just happened to be ending up with uncorrected 20/20. So it's not all like that. Again, I have to set those expectations based on where everyone is individually. For other patients, it would be, our goal, for example, is to get you better vision out of your contacts that you're still wearing, and you'll still benefit from contacts afterwards. You may still have some more nearsightedness left over, you may have some astigmatism left over, and that's going to be correctable with glasses or contact lenses, just like if someone never had keratoconus and was nearsighted or had some astigmatism and no keratoconus, they still have to wear corrective lenses, right? So that's another factor that we have to explain to patients too. Or it might be someone can't even wear contacts anymore, and we do these procedures to try to get them back into contact lenses of some kind. So again, that's part of the goal setting, and it's individualized. Another example there. So yeah, it's really important that we look at each person's degree of keratoconus, and even people's eyes are different. Keratoconus is different per each eye. Typically it hits one eye first, progresses, and then goes to the other eye and progresses. That's why one eye is more advanced than the other often. So even the expectations between each eye is actually different for that reason. So in our study that we did, we compared Intacts alone and Intacts plus Holcomb C3R, and we found we got a synergy effect when we do them both on the same day. And that's why it's a pretty standard for us to do them on the same day, and this shows the K is that number I showed you on the topography. So we get more flattening when we combine the two, which is in red, the combination over 2 diopters of flattening versus just Intacts by itself, which is a little less than 1 diopter. And then this is really the key one. This is the metric of that steep and flat. It's called LU ratio that we developed. And if we do Intacts by itself, we definitely, single segment, get some improvement in the LU ratios, meaning we make the keratoconus less. But the same day treatments, we get almost twice as much improvement in the keratoconus. That's the reason it's really important that we do it both on the same day to maximize the effect and improvement on the keratoconus. And we actually published this study as well. That was back in 2007. Now, another procedure that we'll combine when people have higher astigmatism and also more keratoconus, more advanced stage keratoconus, is CK. And it's not for Calvin Klein, but stands for conductive keratoplasty. And basically what we're doing is we're using a probe that applies little heat spots to the cornea. So I showed you, remember the blue area, the flat area? CK actually helps lift it up. So that's a lifting procedure or steepening procedure, and we put it where the cornea is actually too flat. And so it's not uncommon to combine Intax, CK, and Holcomb all in the same day. In the order, it's typically Intax and CK in the procedure room. Like I said, Intax is usually about a 7-minute procedure, CK is about the same, and then the Holcomb is a half an hour. We'll do at the end. That sort of helps lock in everything with the cross-linking. So here's an example of somebody with astigmatism. Intax was below, CK was above, and you can see here we get the flattening, and also, well, actually we're getting a little bit of the CK, mostly the CK effect here of the astigmatism right there. So this is usually like at a 1-day type treatment. So there's always a little swelling when we combine it. And it can take a little time for it to settle down as well afterwards, for the swelling to go down and for the topography to normalize. And here's sort of another example. This is showing that flattening from the Intax after a little bit of healing has gone and the swelling has gone down. And then you see this is where we corrected the astigmatism or reduced it. It's going 90 degrees to where the astigmatism was beforehand. So in the difference map, it shows the astigmatism that we treated from the CK. Post-op is less up there too. Lastly, the procedure for people who have higher degrees of nearsightedness. For some patients with keratoconus, this certainly can be an option because the ICL, it's a lens implant. It goes inside behind the iris, and what ends up happening there is it's not really treating the keratoconus at all, it's just treating the nearsightedness. So it's also a procedure we use routinely when people are just nearsighted with no keratoconus and they're not good LASIK candidates because they may be too high nearsightedness. They may have a little bit of early steepening on the cornea. And even after people have had Intax and Holcomb, we can look at some cases doing this, for example. There were 2 patients this week we did Visian ICLs on for their nearsightedness after we had treated their keratoconus. And that just shows you where it is behind the iris. And this is the natural lens behind the iris, and this just shows the ICL there. And we have a nice gap or vault, as we call it, where the ICL does not touch the natural lens. That's the goal. We don't want it touching. And we have a special ultrasound that actually measures the internal anatomy as well to make sure we size the lens properly too. A lot of patients may describe their vision afterwards being more like HD. Again, it depends on where they're starting from before we do the ICL. So again, I have to set those expectations based on their individual situation. But if we're doing ICL and Holcomb C3R together on the same day, then it's usually about a 10-minute procedure for the ICL and then about a half an hour for the Holcomb, and then again about a 1-day recovery. So if you're wanting to see some funny things about the ICL, a number of years ago I did a live surgery on the Today Show with an ICL procedure. Patient didn't have keratoconus, it was just nearsightedness case. But there were some funny things that happened behind the scenes. You can imagine with live surgery, there's always, you can't control everything, there's a lot of unpredictable things that happen. So there was one time when they were supposed to be at a commercial break and I got an itchy nose, and I asked Marie, my office manager, to rub my nose, but they had actually gone live already. And so there's literally me getting my nose rubbed by Marie, like live in front of the whole country. So we made a documentary about all these things that happened. So it's on our website called Behind the Lens. And it's an entertaining, short little film that we made about all these behind the scenes things that happened on this Today Show live surgery shoot. But it does give you a sense also about the ICL when you watch the patient go through the procedure too. So just a reminder to request from the office our free UV card to measure your windows. I'm obviously concerned about this enough that Jen's showing one right now. Can you hand one for me? Can I just, oh you have one? Okay. So for all of you watching out there live stream, this is what the card looks like here. It's just a little card and there's a little white strip here. And it's really easy to use. You just put this behind your windshield first. You'll see it won't change too much color. And then put it behind your side window with all the doors closed and obviously all the windows up. And if it starts to turn purple or light purple, then you don't have good UV protection and you should do something about it. And if you just put it outside, you'll see it turn dark purple instantly because obviously all the unfiltered UV just putting it outside. So yeah, contact our office. There's the information. We'll get you the card. Obviously we have our specialties that we do, but also as a doctor, I'm here to help people, and this is one thing why we did the study, because we feel there's a public health safety concern about this with all the skin cancer that's occurring, and people are under a false sense of security driving in their cars that they're protected. And another significant finding I'll just add before I wrap up is that I even thought if there were tinted windows, you're protected. Well, I was shocked because a lot of cars come with some factory tint, and those cars had it was no guarantee they were having full side window protection of the ultraviolet light just because they had a tint. So as I researched it, it turns out tint is only for the visible light you see. UV, it's ultraviolet invisible light. You can't see it, so that's why the film technically that blocks it, it's a clear film. It's a clear film. So some tints have the full protection, but you can't guarantee or take that assumption that you are protected with the tint. So thanks so much for all of your attention, and we have some time for some questions before we break and before Dr. Christina Kinney is going to talk. So thank you very much. Yes, we have a couple questions, yeah.
Hi, Dr. Bryan. It's nice to meet you. I was wondering, you were showing the topography maps. I'm curious about how much that topography can change throughout the course of the day. Body temperature, pH, blood pressure, environmental conditions. I wear hybrid lenses and have for 30 some odd years. And any time during any day, they're either great or they suck. So how much can it vary during the course of the day, or days or weeks? And on that same subject, when you're inserting intacs, are you monitoring the topography real time for placement accuracy and best results, or is it you take the picture, you figure where it goes, you put it in and take a picture later? I'll start with that.
Okay, so you're wearing hybrid lenses?
Yeah.
Okay, so you're probably noticing fluctuation in your vision, not from the keratoconus, but from factors like tear film. Contacts soak up tears, so it's not uncommon to have dryness from contacts and irritation, and yeah, you're going, yep, that's me. So the tear film actually is a big source of stability in vision. So when you're having fluctuations during the day, that's actually not keratoconus changing, it's mostly your tear film, contact lens interface or interaction that's causing that. So, and the second part is when we're planning surgery, we will oftentimes make 2 sets of measurements for people. So we see exactly where they are on the keratoconus and we plan and go with that. That's sort of the system we have. It's worked very well over, with intacs since '99, 16 years. So that's how we would do it. I can't even think of the last time on one of my own patients that I actually did intacs on that I had to do an adjustment for the intacs. So, so that seems to be working pretty good over all these years. Another question? Yep. But by the way, if you're having some fluctuation from contact lenses, you may want to look at doing some dry eye treatments. Really simple one is taking oral flax oil capsules. That's really a good thing for dry eyes. It gets absorbed in your whole body, helps with lubricating your mucous membranes of your eyes, your mouth if you have dry mouth, even your skin. And people with eczema can get big improvements just on flax oil capsules too. Usually recommend about 3 a day, but if people are really having a lot of dryness or bad eczema, up to 6 capsules a day.
Thank you very much, Doctor. Whoa. What causes keratoconus, and is there something that can be done to prevent it? I mean, why do some people get it and others don't?
Great question, and Dr. Christina Kinney is here in the back. And in terms of causes of keratoconus, we're going to wait and see what she says. She's going to answer that question in a lot of detail. And in terms of what can you do to prevent it, well, I think if you have the early stage of keratoconus, certainly you can prevent it with Holcomb C3R, as we've shown. And if you don't have it, but if you have a risk factor in the family history, then you at least want to get your eyes monitored every year with cornea topography. So family history is one reason to be diligent about going to the eye doctor every year to get topography. I mentioned about children of parents with keratoconus. You want to have your kids checked about every year starting at age about 9 or 10 with those cornea maps, because if it just starts a little bit of bulging, it can be nipped in the bud by treatment, just with a non-invasive like Holcomb C3R in that case. Any other questions? Yes.
I had read about a treatment that I saw on the internet that they're trying in Europe with a heated dome or whatever that can actually, it sounded like it would form the cornea into a different shape.
Right, right. Yeah, so there was a treatment many years ago where it was a circular heated area that was applied to the cornea, and it was making a symmetrical change in the shape. So when we look at what the lessons learned are from double intact segments, it's making a symmetrical change. We know, obviously, when you treat keratoconus, you have to do things asymmetrically, right? One area is steep, one area is flat. So whether you do a heat, ring, that's a symmetrical treatment. That's not going to work so well, and it doesn't really seem to have panned out for that reason. When we do CK, for example, which is also a heat treatment, conductive keratoplasty, as you saw, we do it asymmetrically, right? We put it only in one part that's flat, and in fact, the intact is in the other part. So keratoconus is all about helping to restore as much as we can humanly do the asymmetry back in the direction of symmetry. So all these treatments have to be asymmetrical for keratoconus.
My question is, if you get this procedure, say you're in your 30s, and then you have a family history of macular degenera, or is it too early because it hasn't been shown yet?
So if you're in your 30s and you have a family history of macular degeneration?
Correct. It's a family history of it.
And so what's the question?
So if you have the procedure and then say when you're in your 70s you get macular degenera, does it affect the operation that you did?
Oh, okay. So if you are in your 30s, you have the keratoconus treatments done, and let's say later down the road you develop macular degeneration.
Correct.
Does that affect that?
Yes.
There's absolutely no interaction between the keratoconus treatments and developing macular degeneration or being treated for macular degeneration. So in fact, depending on what happens with macular degeneration, the retina surgeon may have to do some retina surgery for macular degeneration. If the cornea is better shaped, it's easier for the surgeon to see what they're doing, because that's like the windshield of the eye, the cornea is. So if it's better shaped after treatments, there's less distortion for the retina surgeon treating the macular degeneration. So yeah, for any procedures, even cataract surgery, right? Let's say someone had keratoconus treated, they developed years later cataracts because that's part of the aging process and related to UV light, like we just talked about. Cataract surgery could be done just like it would be done without the procedures, doesn't impact it. But in fact, the results were better after the keratoconus is treated because the cornea is part of the calculations that surgeons use to do cataract surgery to select the lens implant itself. So the better the cornea is, the better the lens predictability is too. And if someone at the time, we have some patients even in their 60s who develop keratoconus for the first time, or they've had it for a long time, we would always recommend to have the keratoconus treated first and then do the cataract surgery afterwards for that reason. But yeah, that's a good point. Even though keratoconus occurs and starts mostly in younger people in their 20s, but the graph extends out to people in their 30s, 40s, 50s, and even 60s for being newly diagnosed. So it's not just this sort of, as the textbooks would lead doctors to believe, it's not just a disease of like people in their 20s and teenagers. You know, we see it in almost every decade of life, newly diagnosed too.
I have a question for you. With the Holcomb, the C3R, is your vision improved? I mean, I'm wearing the Synergy contact lenses now, and I have the halo, I have all that kind of fun stuff. But as far as doing that, does your vision improve, or do you have to do the other things? I also have Intacs.
Yeah, so the question is, does Holcomb C3R improve your vision? And the answer is, the goal of the procedure is to stabilize the vision and stabilize the keratoconus. However, some patients get a little bit of improvement in vision. It's like a bonus if it happens, and it's not anything compared to what the Intacs can do to the cornea because that's mechanically flattening the cornea, sort of like a bra supporting it. But the main goal is to stabilize and stop it from progressing. And if there is a little bit of improvement in vision, which sometimes can happen, that's like a bonus. But that's not the goal of the procedure. That's when Intacs come in to help improve the potential vision by helping to reshape the cornea.
Because when I had the Intacs, my vision improved for maybe about a week, 2 weeks, but I'm still wearing the Synergy. I would love to see how we can, vision-wise, be able to.
Yeah, I mean, if you had Intacs before, I mean, if you live locally or even if you're out of town, I mean, you obviously could come in for a second opinion, and I can see where the Intacs are placed. Like we talked about, there are various factors where Intacs don't work out so well. But again, if somebody was more advanced keratoconus and Intacs was done, then the goal for them is not to get out of contacts, it's just to either get better vision with contacts or get more comfortable with contact lenses. So it depends, again, it goes back to when I was discussing the stage of keratoconus for each person, and that's why I have to really individualize the expectations so people know what to expect individually. That's a good question. Yes, sir.
How you doing, doctor? I'm one of the
Great.
lucky ones whose keratoconus got more advanced before I found out about your procedure, and I didn't know if if it gets too advanced that you might not can use any procedure. Basically, you know, for instance, I have scar tissue in the left eye. Is there any procedure that can help correct that?
Okay, so a gentleman asked the question of having more advanced keratoconus, even having scar tissue. Is there anything that could be done to help? So we can always, even in the most advanced cases with the thinnest of corneas, we can always still do Holcomb C3R safely. The other procedure, CXL, there is a limit. It can't be safely done if the cornea is too thin, for example. But again, because we're non-invasive, there hasn't been anyone we couldn't treat with Holcomb C3R, basically. So regarding the scar tissue, then it depends if the scar tissue is causing problems with vision on top of the keratoconus or not, and that's only I can assess that when I do the exam and look at it. Because some scars are flat on the cornea, and some are actually raised up, like a nipple or like a callus. And if it's raised up, it can cause a lot of contact lens problems. And then we have a laser technique that we do where we can actually bring it down so it's flush again, so the contact lens isn't rubbing on the scar. And so it just depends on that in terms of if the scar is treatable or non-treatable based on the characteristics of it with the contact lens. But we can determine that during an evaluation in the office, yeah.
Thank you, Thank you, Dr. Bryan. I have 1,000 questions, but I'll limit myself right now.
Okay. And by the way, that's a good point. I mean, if you if you can't get all your questions answered, the staff's around, I'm around, in live stream out there. You can contact the office. So, you know, we really want to make sure you get all your questions answered.
I'm probably the biggest baby in the room when it comes to doing anything to my eyes, and it took a long time for me to even be able to get lenses in. And so this kind of, even though it sounds safe, etc., scares the hell out of me. Does the intact actually go in through the cornea, or is it periphery? That part wasn't clear to me. And, you know, I just know that corneal abrasions hurt like hell.
Yeah, they do.
So I guess that's my number one question right now.
Okay. So the intacts go below the surface of the cornea. So we use numbing drops when we apply it. So the typical experience is patients will say, I didn't feel a thing. There was no pain at all. Maybe just a little pressure. So if you've been to the dentist, intacts is typically easier than going to the dentist to get your teeth cleaned. So how are you at the dentist?
Sort of okay.
Okay. So this should be even easier than getting your teeth cleaned at the dentist.
And this is actually less invasive than even LASIK.
That's
So,
good. This is less invasive than
yeah.
LASIK. Good point.
A lot of patients are shocked by that, so I just wanted to add that.
Yeah. So I mean, obviously, vision is the most important sense we have, right? I think a lot of people would agree with that. So, and we do LASIK too. We do a lot of LASIK, and usually people are afraid of LASIK because it's like my eyes, and they wear contacts and glasses. So, I mean, Holcomb's T3R is completely non-invasive. It's like vitamin drop solution and light for a half an hour, and it's a one-day recovery. And it might feel a little scratchy afterwards for that day, and that's typically about it.
I promise to not ask anymore. But you when you were talking about the brain dead. When you were talking about having the cornea transplant, you said the secret is that they don't tell you that you could blow out your eye essentially. How stable and how strong is the insertion, or where you put the intact? I mean, is that still a big worry, or is it reduced worry, or no worry?
It's really no worry in terms of weakening the cornea. It's about a 1 millimeter opening where we make the insertion, and the intacts, like I showed you, it goes underneath the surface, like again, putting a pencil in between a book. So it doesn't weaken the cornea at all. Yeah, the intacts aspect of it.
Hi, doctor. Thank you for this symposium. It's very informative. As a parent, when we take our kids in for their physicals and their vision, keratoconus is not something that a doctor would normally look for. And the fact that I'm here with my daughter and she has it, and she had a cornea transplant, I as a mother feel like a failure that not knowing, I mean, I don't know what I don't know, but I'm trusting doctors when I take them in for a physical that they're going to run the gamut of the possibility. That's not something that they would normally look for, keratoconus or the traits.
Yeah, I mean, just hearing you say that, it just sort of makes me pause and sort of have to almost hold back a little bit because, you know, I mean, you saw in my TEDx talk, you know, I got very emotional about this, right? Because, again, that's the Hippocratic Oath, right? Is to do no harm and to be an advocate for patients. That's what doctors are supposed to do. You should not feel guilty about this, okay? That's really important because of a failure of some doctors in the field to inform you. You can't hold that on yourself and feel responsible for that, okay? I would hold the doctors responsible for not telling you about these other treatments and then saying she needs a transplant, okay? I think that's the most important thing because, I mean, you know, some parents can live the rest of their lives with the guilt, and I think it's really important that you just do not feel any guilt on this, okay? Because you're her parent, you love her, you do a lot of things for her, right? As a mom, especially. So I think that's the most important take-home message for you for this whole day, is that you did the best that you could with the information that you had and were given at the time. Okay. But even after cornea transplants, there are some, because a lot of times a transplant will cause a very high amount of astigmatism, and that can be even oftentimes worse distortions than the keratoconus was. Forget about all the other extra risks of having the transplant. But we have a laser technique called PRK that we can do. It's a surface laser that we do over the transplant, and actually it can make dramatic improvements in the astigmatism and help improve vision a lot as well. So, so that's another option in case there's a situation where somebody has a transplant and they have those other things. But point is you know, you're here obviously because you care about her welfare, and you should not feel any guilt about the fact that you weren't given all the proper information by your doctor. Okay? And that's why we try to get the word out, because for years it's been this battle so that against doctors and their egos, because a lot of times if a doctor doesn't themselves have the procedure that they offer, it's not uncommon that they will just not mention it to the patient. And that shouldn't be. There are procedures that I don't do, and I'll tell my patients, well, you should go see so-and-so, who might even be in another country that does it, even though I don't do it, right? That is no ego, right? It's in the best interest of the patient. And the doctors who have that will have no problem saying, even though I don't do it, maybe you should look into it, do a little research on the internet, or here's the name of a doctor who does it. That's the sign of a really good doctor, right? Not having the ego get in the way of patient care. But you should not feel bad, not feel guilty about this. You just need to make sure her eye is protected, you know, if she's doing any sports or anything like that, because, you know, those risks I talked about of trauma to the eye. Okay. So we're going to wrap up. We're going to still be here for other questions and Q&A, and we're going to have a break, and Jen's going to come up and you want to announce we're having a break? Do you want to announce we're having a break?
Having a break.
Okay. She announced we're having a break, so we're having a break.
Please break.
And then what time are we coming back? At 11?
Yeah,
for Dr. Kinney?
Yes.
She's going to talk about the causes of keratoconus, and she also just got back from one of the biggest research meetings in the world, and is going to be reporting on her findings of also the latest on what causes keratoconus as well. So I'm also really interested to hear what she has to say in terms of the updates there too. So Jen, what time are we coming
Okay,
back?
so coffee break. We're going to come back right before 11 a.m. To talk with Dr. Kinney. It's 11 a.m. Oh, I'm sorry.
So we're coming back coming
yeah,
back at
so
11?
just a few minutes. It's 10:53.
Okay.
So
about
maybe
10
like
10
10,
minutes?
15 minutes. Okay. Yeah,
Okay.
10, 15
so about
minutes.
That 10, 15 minutes.
Feel free
we'll
to help
be
yourself in the back.
So
Yeah.
if you're out there in live stream, make sure you come back. Don't miss Professor Kinney's talk. Thank you.
He'll turn it up. I can hear it. It's working.
Okay, everybody, we're going to go ahead and get started and take a seat. I'm going to introduce Dr. Kenny in just a moment, but I wanted to give a big thank you to Oasis Medical, who is actually sponsoring this event. Kevin, do you want to wave and say hello? He's actually yeah, thank you. You want to stand up? All right. Thank you so much, Kevin. He actually has a table outside. If you haven't already seen it, he has brochures and even samples of some artificial tears. But I just wanted to thank you so much because we really appreciate you guys and everything that you do. Obviously, we love your product. So everybody, if you can give another round of applause for Kevin. Thank you. Okay, so I want to introduce Dr. Christina Kenny. She is also a PhD. She's a professor and director of laboratory research at the Department of Ophthalmology at UC Irvine Medical School. She's been a part of the nonprofit organization Discovery Eye Foundation for over 25 years, which is an organization that is dedicated to keratoconus education and research. Obviously, you know that's pretty important. She's very highly accomplished clinician scientist and recognized as a pioneer in the field of genetic and biological research in relation to keratoconus. She is a recipient of numerous research awards from the National Institutes of Health and private foundations for her work with keratoconus. She's also published over 25 peer-reviewed manuscripts on keratoconus. There's a she also has a PhD from University of Arizona, her MD degree from UCLA, postdoctoral biochemistry fellowship at USC, and ophthalmology residency at White Memorial Loma Linda University. So I want to give her a warm welcome, and she's going to come up right now. Thank you.
Jen, thank you very much. And I think that you can hear this. As you have probably figured out from all of that, I've been interested in keratoconus for literally decades. I think it's a fascinating disorder, and I can't tell you how far we've come in biologically. From a scientific point of view, it's fascinating. But I can't tell you how far we've come in what we've learned in the last 2 decades. So what I'm going to do today is, first of all, I'm going to review the structure of the normal cornea. And then I'm going to discuss the pathology of keratoconus corneas, focusing on 3 things, because these are the 3 things that are important for keratoconus. There's corneal thinning, there's anterior corneal instability, and there's high levels of oxidative damage. Then I'm going to talk about some of the molecular mechanisms, and we're not going to get into equations or anything too complicated, but just the overall concepts. And then I'm going to discuss some of the genetics, because people say, gee, I have it, but nobody else has it, or it runs in my family. So we're going to talk about that. And then finally, I'm going to summarize the research from a very large international meeting that was just held in Seattle, actually 2 weeks ago. So this is a diagram of the normal cornea, and I think most of you know the cornea is the clear part of the eye, and this is a schematic of a cross section. So if you take a piece of cornea and cut it in cross section, the cornea actually has 5 layers. The first layer is the epithelium, which is a layer of cells, then Bowman's layer, which is this matrix that the epithelium sits on. and then the stroma, which is the bulk of the cornea, and then a specialized membrane called Descemet's membrane, and then a single layer of cells called endothelium on the back of the cornea. This is just what a cornea looks like, that it's been sectioned and stained, and you can see here's the epithelium. You can see the bulk of it is the stroma, and then the endothelium. Now, in the cornea, 70% of the total dry mass of the cornea is collagen. And I think most of us are familiar with collagen. There are two kinds of collagen, the fibrillar collagen, such as the kind that you find in tendons and skin, and then there's this non-fibrillar collagen. And the non-fibrillar collagen acts as packing material. So the fibrillar collagen makes a structure or a scaffold, and then the non-fibrillar collagen sort of tacks it together. And then with that scaffold, you need packing material. And that packing material are called proteoglycans, glycoproteins, and different kinds of other proteins. The secret of the cornea is that when you put all of this together, it attaches to each other. It doesn't slip. You've got connections and anchoring fibrils and things that really keep it firm. And this is just an example of this diagram is a scanning electron microscope. It's blown up 1,000 X magnifications. But the point of this is that the cornea is actually layers that are interwoven. And you can see this is one of the layers here, a lamellae, and you can see it's bifurcating here, that's another lamellae. And here you can see this one goes above it, and that one goes below this other lamellae. And the point is, it's sort of like a basket. It's all woven together, and that's part of what gives it its stability. Now, in terms of keratoconus, it's stated that the incidence of keratoconus is about 1 in 2,000 individuals. It usually appears in teens and 20s, but as Dr. Bryan said, it doesn't have to. Sometimes people are younger, sometimes they're older. It's usually unilateral in only 10% of the cases. Most of the times people have it in both eyes. And there's a family history in about 6 to 10% of the patients have this family history. Now, when people do studies on keratoconus, this is just the basic study design. They obtain the corneas from transplants. They also get normal corneas. Is it from here? Okay, normal corneas. And once you get those corneas, then to analyze them, some people culture the cells, other people isolate the DNA, RNA, and proteins, and then other people get the corneas and then look at them with various kinds of microscopes. So, as I mentioned earlier, there are 3 pathological features of keratoconus. And the first is corneal thinning, second, anterior stromal instability, and the third is oxidative damage. And what we're going to show that all of these features are related to each other. Now, why does the cornea thin? What's different about the keratoconus corneas? People have been doing studies, and they found that the keratoconus corneas have increased levels of what are called degradative enzymes. These are enzymes that are present normally in our body, but they're inactive. But with keratoconus patients, they have a lot more activity, and therefore they degrade and chew up the collagens and the proteoglycans that are in the cornea. The second thing is normally there's a balance between these degradative enzymes and inhibitors. But what happens with keratoconus patients is that the inhibitor levels are lower. So you have lower inhibitors, and therefore you have higher levels of enzyme activity. Now, people have been studying this since the 90s. There was a lot of effort in the 90s to identify these different enzymes. And you can see it wasn't just one enzyme that was more activated. There's a whole host of enzymes. There's lysosomal enzymes, this category, cathepsins, and then these categories are the ones that digest the collagen, the matrix metalloproteinases. digest collagens. They also showed in those years, the 90s, that they have decreased levels, not just of one inhibitor, but of multiple inhibitors. The tissue inhibitor of metalloproteinase, and this proteinase inhibitor and the macroglobulin, they all inhibit different pathways. So then this is like a double whammy, because it's not just one single pathway that is changed, and therefore we can go over after that one inhibitor or that one enzyme. There are multiple enzymes that are increased and multiple inhibitors that are decreased. So the consequence is this. Normally, you have collagen and matrix that's produced, and it's in balance with the normal degradative enzymes. It's normal to have degradative enzymes. If you didn't, you would just keep having so much matrix, and there are diseases where you don't have enough degradative enzymes, and it's not good. But with keratoconus, you have increased activity of these degradative enzymes, and therefore you have thinning of the matrix. Now what the result of that is here's our schematic again. Here's our epithelium here. Here's our Bowman's layer. Here's the stroma, and that stroma is packed with all the different kinds of collagens. It has proteoglycans, it has glycosaminoglycans and different proteins. You have Descemet's membrane and the endothelium. So there's a normal thickness to a cornea. But with all those degradative enzymes, then it chews up all of that matrix in the stroma. So you get a lot of thinning. And in addition, in the Bowman's layer right here, the enzymes degrade a lot of the Bowman's layer. The second feature is the anterior corneal instability. And I'm going to present 3 different studies that were done using different approaches, all of which came to the same conclusion, that keratoconus is mainly a problem with the anterior part of the cornea and not really so much involving the posterior part of the cornea. The first study was published in 2009 by Keith Meek, who's in England, and he had noticed that, yes, you have the increased degradative enzymes, and it weakens the matrix, and this causes stress and tears in the stromal layers, especially around the apex, the base of, and the base of the cone. So what they did is they used this very special instrument, this wide-angle X-ray instrument that measures scattering patterns of the fibrils. And so they can actually look at how the collagen is spaced. And this is the normal cornea, and I think you can see that the patterns here, they're very uniform for their patterns, as opposed to the keratoconus cornea, that you can see there's a lot of irregularity with the fibril arrangement. The second work that was done was by Dr. Bermanson, and what they took, it was a really tough project, because what they did is they took normal corneas and keratoconus corneas, and they did serial sections, and that means one section after another section after another. So they made ribbons of sections of corneas, and they looked at hundreds and hundreds of corneas, because they wanted to trace the fibrils, because we didn't know if they were stopping, fragmenting, what exactly was happening. So he worked on this for a number of years, and what he found is that there was the thinning of the Bowman's layer, but he also found a lot of fragmentation of the stromal fibers, excuse me, and loss of that interweaving that we saw earlier. Excuse me. And this just shows, this is a normal cornea. Now this is a transmission electron micrograph. So you've taken this cell and you've blown it up to the size of, this size. So this is just one part of one cell. And this is the Bowman's layer. But in a normal cornea, you can see how thick that is. But in a keratoconus cornea, it's much, much thinner than in the normal. The other thing that's very important is as these layers break down, then the epithelial cells, the cells that are supposed to be separated from the main part of the stroma, they start to invade in. And they're areas that they again cause weakening. So the third study was published in 2007, and they used a confocal microscope. And this is a very, very fancy microscope that it doesn't use light to look at the images. It uses a laser, this femtosecond laser. And it generates these signals. And with these signals, you can actually look at the collagen in the corneas. And so he also looked at normal and keratoconus corneas and then reconstructed three-dimensional maps of these corneas. And this is what a normal cornea looks like. Here's, again, your epithelium, your Bowman's layer, your stroma, Descemet's membrane, and endothelium. And what they found are these, what they called anchoring fibrils. They go from the anterior part of the cornea to the epithelium. And here you can see them in the normal cornea. And they're literally anchoring the epithelium and the Bowman's and the anterior stroma. So it's really providing stability. Well, what does a keratoconus cornea look like? Keratoconus cornea barely has any of these. They really, really are absent. And so again, if you don't have all of these little anchoring fibrils, you're going to get instability. So here's your keratoconus cornea. You've got thinning of the Bowman's layer. You've got fewer anchoring fibrils. You have less matrix. And so when you have the normal pressure that you have in the eye, it's going to bulge it out. And so that is part of the mechanism by which you get the bulging. Oops. The third aspect that I'm going to talk about has to do with oxidative damage. And the first thing I'm going to do is give you some definitions. Reactive oxygen species and reactive nitrogen species we refer to as NOS or NRS. Oxidative stress is when you have an altered balance between how much ROS you're producing and how much you remove. ROS is the same thing as free radicals. Hydrogen peroxides, superoxides, things like that, those are free radicals. Those fall under the category of the reactive oxygen species. If you have oxidative stress, then instead of getting rid of those free radicals, they accumulate and they cause damage to the tissue. When the tissue is damaged, then you have decreased cell function and cell death. Now this is, I want you to memorize this because we're going to have a test afterwards, and you can't leave until you pass it. No, this is just basically a series of biochemical reactions by which free radicals are formed or reactive oxygen species are formed, okay? And so the reason we have it is that everything that's in yellow has been shown to be elevated in keratoconus corneas. So normally you'd have this, all of these are reactive oxygen, nitrogen species. Here's hydrogen peroxide, but they're all elevated in keratoconus corneas. Everything that has a little asterisk by it, all these little enzymes, these are various enzymes, catalases, superoxide dismutase, those are all enzymes. Those are all altered in keratoconus corneas. So you can see, if you just take a keratoconus cornea and you look at it, everything's off balance, it's off kilter. The enzymes aren't working right, you have too much reactive oxygen species, and that can be a problem. Now, this is just to simplify it, is, okay, here we have the reactive, the ROS and RNS. Where do they come from? Just ultraviolet light, sunlight, as Dr. Bryan was saying. Rubbing the eyes too hard can irritate the eyes. There's an organelle, or there's a little tiny structure inside a cell called mitochondria. They normally produce reactive oxygen species. It's normal to have these. Everybody has them. But fortunately, we all have antioxidant enzymes that get rid of and keep everything in balance. But with keratoconus, as the previous slide showed, we don't have all those antioxidant enzymes. So what happens is that you have an accumulation of the ROS, and they are funneled through different pathways. One pathway is called lipid peroxidation, and that forms aldehydes. Well, we know aldehydes aren't good. And the other is through the nitric oxide pathway, and those are formed peroxynitrites. Both of these cause oxidative damage. When you have oxidative damage, it feeds back and increases the degradative enzymes. So it's sort of like a cycle that is occurring. Oh. So how do we know that we have elevated peroxynitrites? There was a study done in 2002, and what this group did, actually it was our group, what we did is we took normal corneas and keratoconus corneas, and then we took corneas that had other diseases, and we analyzed for the amount of peroxynitrites. And you can see in the epithelium, the stroma, and the endothelium, the keratoconus corneas had much, much higher levels of the peroxynitrite than the normals, and even higher levels than corneas from other diseases. Now, I also had mentioned that the mitochondria generate some of the ROS. So what are mitochondria? So now we're going back to high school biology, okay? So here's a cell. Here we have the nucleus of the cell, and what mitochondria do is they provide energy for the cell. They're like the batteries for the cell. So every cell has mitochondria. We absolutely need them. Now, mitochondria are really special and unique because in a cell, in the nucleus, everybody knows we have DNA. You get half your DNA from your mother, half the DNA from your father. Mitochondria have their own DNA, and you only get it from your mother. Your dad doesn't give you any of the mitochondrial DNA. So that's what makes it so good to analyze. And the other thing is unlike the nuclear DNA, which is the double helix that we all learned about, the mitochondrial DNA are little tiny round circles that are found within the mitochondria. So what we did for this study, we extracted the DNA from normal and keratoconus corneas, and we used various techniques. And what we found is that the mitochondrial DNA had a lot more damage than the normal DNA. So if you look at the average here, this is keratoconus. The average was 7.4. It's almost double what the number of defects that were found in normal. So why is that even important? It's important because the defects, if you have defects in mitochondrial DNA, that can lead to increased ROS production. If you have increased ROS production, you're going to get decreased energy levels, because that's what the mitochondria do. The function of the mitochondria is to give you energy. If you don't have enough energy, the cells stop functioning. They just give up. They can't. They require a certain amount of energy, and once they really give up, then they die. So again, this is just going back. It looks complicated, but it's just I'm trying to get the concept there, that you have all of these pathways involved with the elevated reactive oxygen species, with the abnormal antioxidant enzymes. They can cause damage to the DNA. Here our mitochondria is damaged, and then this feeds back, so you get more ROS, more oxidative stress, and it's just a one big circle or a cycle that's happening. So when we ask the question, are these events related? The question is yes, because if you have oxidative damage, it's going to cause thinning because of the increased enzyme activity. The increased enzyme activity is going to digest the matrix of the cornea, and that makes the cornea unstable. So the cells that are in the cornea, they don't like it. They become stressed, and then they produce more oxidative damage. Now, I'm going to switch gears a little bit because there was a very interesting paper from last year that was published, because everybody sort of thinks, okay, all of this is going on in the cornea. So this group wanted to know, well, how about in the tears? Are the tears, can you follow keratoconus patients, or can you identify markers in tears? So what they did is they collected the tears and the epithelium from normal patients and keratoconus patients. And they found, when they analyzed them, that the tears had higher levels of the degradative enzymes and inflammatory proteins. These should not be at high levels. And in the cells themselves, they had high levels of the degradative enzymes and even a greater number of inflammatory proteins. So what they said is, okay, there's oxidative damage, stress going on. What if we treat the patients for 6 months with an anti-inflammatory product? And that's called cyclosporin. It's an eye drop that is, can be used in ophthalmology. And they treated it for 6 months, and they found if they did that it reduced the levels of some of these degradative enzymes, and there was a local reduction in the curvature of the cornea. Now, they are starting clinical trials. When people start clinical trials, they're assigned certain numbers, and so they're working on that. Here's the clinical trial number. I don't know where they are with the clinical trial. I don't know how long it's going to be going, but this paper was just published, so it may still be ongoing. So that's sort of where the background of keratoconus and why it happens. So what I'm going to do now is I'm going to switch to the genetics of keratoconus. And people have been looking at the genetics of keratoconus for 20, 25 years. Now, again, high school biology. In every cell, you have DNA. The DNA codes for the RNA. The RNA codes for what are called amino acids. When you string the amino acids together, that forms a protein, and that protein gives you a function. So that's, now what we're going to do is look at the DNA, because if the DNA is bad, then this is all going to get messed up and the function's not going to be good. Okay, so how do we know that genetics are even involved in keratoconus? People have shown that there's increased keratoconus in identical twins compared to the general population. So if one twin has it, if they're identical twins, the second twin is going to also have it. Second of all, as I mentioned before, 6 to 10% of keratoconus patients have one or more family members with keratoconus. Now, this is a very, very good article that just came out in 2014, and what this group did is they took all the studies that had been done all over the world on keratoconus and genetics, and they put it together as a big review. And what this table shows are, these are different chromosomes, and we're just doing general stuff. They're different chromosomes, and these studies were done from studies from Australia, from Italy, from Saudi Arabia, Hispanic and Caucasian, Italian, Finland. The take-home message of this slide is that 16 chromosomes have been associated with keratoconus. It's not one chromosome that everybody has and then you get keratoconus. It's 16 chromosomes that have been identified. What this slide does is, rather than look at the chromosome, they've looked at specific genes. And again, the take-home message, and this time they've looked at people from Ecuador, Korea, China, Japan, Europe. At least 20 of the genes have been associated with keratoconus. And finally, the VSX1 was the very first gene associated with keratoconus. So you think, okay, there's one gene associated, it's going to be very straightforward. No such luck. At least 8 different variants of that gene have been associated with keratoconus. Not only that, keratoconus has been associated, many people just have it in their eye, they don't have any other systemic problems. But there are many disorders, such as Down syndrome, that have people with Down syndrome have a very high incidence of keratoconus. Some studies say 10 to 300-fold higher, and along with these other syndromes. In addition, there's some very rare syndromes that you hardly ever see. I haven't seen 80% of those syndromes I've never seen. So they're very, very rare. But in the literature, you can find that those people oftentimes will have keratoconus in addition to this syndrome. And that's also true for the Marfan syndrome and the Ehlers-Danlos syndrome that we were talking about. Yeah, right there. The take-home message for all of this is that the genetic cause of keratoconus is very heterogeneous. There's not one single gene that is associated with keratoconus. And the keratoconus it's a very, very complex disorder. There are multiple genes that are involved. Now, there are modifiable risk factors because we know that oxidative damage and oxidative stress plays a role of that whole cycle. So there are the risk factors that we can modify are the exposure to light, the eye rubbing, poorly fit contact lenses, and chronic irritation. But I've always felt that if we were going to treat keratoconus in a non-surgical way, that you really have to identify and intervene in the common pathways and you can't target one gene that you're going to replace in the individuals. Now this is my view of the cornea. So with the normal cornea, we normally have stress, we go outside, we rub our eyes, we do various things. It produces some ROS, but we have a lot of enzymes that just come in and get rid of that ROS, so you don't have damage to your mitochondrial DNA and you have normal functioning cells. But in keratoconus, what happens is those patients can be exposed to the exact same stress, but they have abnormal enzymes, and so those abnormal enzymes can't remove the ROS. So there's an accumulation of the ROS. When that happens, you get some mitochondrial DNA damage. It causes some damage to the cells. More ROS is produced. They have abnormal cell function, and we know that the ROS can activate the degradative enzymes, and that's going to lead to corneal thinning. So what can we do about it? We've gone over a lot of things. You know, we've got a pretty good idea of the kinds of things that are going on, but is there anything that we can do? Well, there are two categories of risk factors. There's the non-modifiable risk factors, things we can't do anything about. Our family history, our age, our gender, our genetics. But there are modifiable risk factors, such as smoking, obesity, eating habits, rubbing eyes. These kinds of things generate oxidative stress. So the goal, what I've always recommended for patients, is to really try and control some of the levels of the oxidative stress. And for patients, very simple things like use really good protective. It's, as Dr. Bryan was saying, check whether or not your car is letting in the UV light. Get some good sunglasses. If you have contact lenses, do they have UV protection? A lot of keratoconus patients have what's called atopy or allergies. Their eyes itch all the time, and so they rub them. Well, we want to avoid vigorous eye rubbing because, again, that can stress the cells. Some people, they'll have contact lenses. They know the contact lenses don't fit. They can tell, they can barely stand them. If those contact lenses sit on there, they're going to rub and irritate, and it's just going to cause more problems, and that's going to cause inflammation. So what I've always recommended for patients is that you use the protective UV protection for your glasses and your contacts. Get properly fit contacts. Nowadays with the scleral lenses and some of these other lenses, you know, they've made real strides in a lot of the contact lenses, and I'm sure that you have some very good expert contact lens fitters, and I think The number one thing that keratoconus patients learn very early on is you cannot go to Sears and get your contact lenses or Costco. It doesn't work. You need somebody that knows what they're doing. If your eyes are irritated, if you tend to have allergies, then don't just ignore it and say, okay, well, that's okay, it just irritates a little bit. Be aggressive about either getting allergy medications, non-steroidal anti-inflammatory eye drops, or this cyclosporin drop. You can get these through your physician, your eye care physician, and really try and keep things down, because if you generate the ROS, you don't have the enzymes to get rid of them. So the goal is really to minimize it. And the other thing I've suggested is that try and adopt a healthy lifestyle such as we have for AMD patients. Age-related macular degeneration is the most common cause of vision loss in the elderly population. It's in the back, it's in the retina. It has nothing to do with keratoconus. But the National Eye Institute has put in millions of dollars to study antioxidants, treatments, and lifestyle treatments to minimize the oxidative damage that occurs in AMD patients. Now, they're not going to do that with keratoconus because it's first of all, we can learn from their studies, and there's not as many people. It's a tougher group. It's a small group compared to how many people have AMD. But there's no reason why we can't learn from the 35 studies that they have done. And the number one thing is smoking. Smoking is so toxic to the eyes, and in any case, I would definitely recommend stopping smoking. And in terms of diet, all the green leafy vegetables have a lot of antioxidants. The keratoconus patient may not be making antioxidant enzymes, but you can take them in, and you can substitute. The red meat and the high-fat dairy products they're great once in a while, but it's better not to eat them all the time. The studies have found that fish has high omega-3 fatty acids, and they are very, very good for decreasing oxidative stress. So the AMD studies have recommended fish 2 or 3 times a week, and also any kind of nuts. Now, as I said before, the green leafy vegetables, tomatoes, the vegetables with colors, the kale, the spinach, things like that are really good. Now, let's say I can't stand fish, I'm not going to eat any vegetables or anything green, forget it, fine. Take a supplement, because they've shown that you can get equal effects by taking supplements, vitamin supplements, as by eating the fish. But do one or the other and really try and increase your antioxidants. The thing about a healthy weight is people have done studies, and people have found that if people are overweight, that in their blood, there's certain factors that are increased expression, the inflammatory factors. So again, it just increases the inflammation that's going on in the body. And that's one reason that sometimes people that have obesity have more medical problems. So then part of this that they've done is they found that studies also are very good to help control your oxidative stress levels, and getting regular eye exams are extremely important for all of this. Briefly, I'm just going to talk about the meeting that was just happened 2 weeks ago. This is a big international meeting that was in Seattle. There were over 5,000 participants and over 6,500 presentations, and over 100 of the presentations were solely on keratoconus. There's so much interest in keratoconus right now. About 24 of the presentations were molecular biology, what factors are increasing, decreasing how do you control them? How do you regulate them? There were some studies on genetics, but again, nothing saying, here's the magic gene that causes keratoconus. Most of the studies were clinical presentations, and the most exciting part has to do with the cross-linking, because everybody, finally there's some way to treat keratoconus with the cross-linking. And there's so many studies that are looking into how to modify it. Instead of using the riboflavin, people have come up with other cross-linkers. Instead of using the UVA light, people are trying to use a laser to get it more focused. So there's a lot of new stuff that's going on. So there's a lot of interest in a lot of things that are on the horizon for the keratoconus patients. Finally, I just want to say for anybody with keratoconus, if you haven't if you're not aware of the National Keratoconus Foundation, it is a nonprofit organization that was started by somebody that had keratoconus, and the whole reason he started it was he said, I have keratoconus, nobody knows what it is. People look at me and say, well, you know, what are you talking about? You look perfectly fine. And he said, I want people to know and to be able to communicate with other people that have keratoconus. So they have a KC link where people blog back and forth. Oh, I have problems with my contacts, or have you tried this or that? They have newsletters, they have educational seminars. And the other is, again, a nonprofit, Discovery Eye Foundation. This foundation has supported keratoconus research for the last 30 years. And they're both these foundations are very committed to keratoconus and the keratoconus patients. And if you haven't, been in contact with them, the other thing about the National Keratoconus Foundation is they have books. They can send you books and booklets about keratoconus and other things. So they're both really, really worthwhile foundations. And I just want to acknowledge many of the people that I've worked with and that have provided for these studies. And I just want to say thank you very much. And I'm open to any questions.
Dr. Kenny, really appreciate it. It's very interesting, your work.
I hope it was, you learned something. Okay,
Yeah,
good. That's the main thing.
Does anybody have any questions? Oh, okay.
Hi, thank you. Other than eating the proper diet, are any of the antioxidant supplements worth taking?
Oh yes, absolutely, absolutely. They have, when the AMD study was done, they developed some vitamins that had antioxidant components. And in any part of the drugstore, you can go to the eye supplement portion, and they have things like zinc, vitamin A, vitamin C, and some of the other antioxidants. But yes, my own feeling, if I had keratoconus, I'd be taking a lot of antioxidant.
You also mentioned
supplements, yes.
the treatment or the care taken is the same for macular degeneration, the age-related macular degeneration?
Well, I am sort of taking what I know about AMD and taking what I know about keratoconus and saying, you know what, we could learn something from the AMD people. They have not done a study, nobody's done a study where they say, you know, does it progress or not progress. But for these antioxidants, for the food, the lifestyle, the antioxidant supplements, I just don't see a lot of downside to it. And I know the keratoconus has a lot of elevated oxidative damage. So, you know, from my point of view, it's a low risk.
The reason I ask is as we've aged, we've come in contact with these AREDS 2 formulas.
That's what it is. It's AREDS.
Would someone with keratoconus who's not old be helped by taking those?
I mean, because they're basically vitamins. There are formulations of, and the ARED stands for age-related eye diseases.
Right.
And so they, like I said, the National Eye Institute invested over probably 2 decades, and they completed probably 35 separate studies. And they asked about cataracts, and they asked about AMD, and they asked about some other things. But they did not ask about keratoconus. It just wasn't on their radar screen, but I don't see, from my point of view, I don't see how it could hurt.
Hi, have you come across, as you demonstrated a keratoconus cornea having been degenerated from these degenerative enzymes and the breakdown, have you come across any incidences where there was any restoration because of techniques, whether it's better antioxidant intake, and where they actually, the cornea is getting better on their own?
Well, the format of our studies were, when we were doing many of these studies, there were a lot of, there was no cross-linking. So a lot of people were having penetrating keratoplasty. So they were having their corneas exchanged. So we were getting them from the pathology. So we didn't really have a way to treat it. But we did in tissue culture add some antioxidants and cut down on the degradative enzymes and things like that. And I know there's some small studies using some of the non-steroidal drops to number one, make the patients more comfortable, and decrease the sort of discomfort that they have. And but they haven't followed them out for a long period of time. And I think that's what the clinical trial, because one is patient comfort, but there are some parameters such as measuring the enzymes in the tears and in the corneal curvature that you could do long term. But that has not been done yet.
But we haven't actually seen any corneal restoration through any technique. Okay.
But I can say, just in general, if the balance of tissue, any tissue in the body, you have collagen and matrix produced, and then it's degraded. There's a constant turnover, and that's true for the cornea.
Would cross-linking in any way obstruct regeneration because you're locking something in?
I don't think so, and the reason not is that the cells are still present. So the only way it would obstruct it is if it damaged the cells, so the cells die in the stroma, because then you wouldn't have the mechanism to produce the collagen. But if the cells are alive, they're going to do what they do, and they're going to produce collagen.
Okay. Thank you.
All right, so let me make my way over this way. Thank you so much for your question.
So based on all of the suggestions you had, like the diet and the exercise, the drops and whatnot, my husband has keratoconus, and we have a son who's only 5 right now, but are there things that we can do, such as the things on that list, to help him so that maybe he doesn't end up with it? Or is it just...
Does anybody else in the family have it?
My mother-in-law.
Okay, so it does run in the family. So then I think there are, using the UV glasses, if you find him rubbing his eyes a lot, that
make it stop.
Yeah.
Okay.
But you can't just say don't do it, because he's rubbing it for a reason. It's
they itch from the allergies.
They itch from allergies.
Right.
And so, get some anti-allergy drops. Preservative-free artificial tears are really, really great. A lot of times what people can do is if you put them in the refrigerator so they're cold, and then you put them in, they feel better.
Okay.
And so if you can just try and break that cycle of itching and the eye rubbing, those are the kinds of things that would be helpful.
Sorry. One question. Your slideshow has a lot of great information, but it's very information packed. I was wondering if maybe it'll be available somewhere or to just remind ourselves, like notes and.
Sure, I can. You know what I could do through DEEF, the Discovery Eye Foundation, I could put it up, and then people, and if you go on there, you can link to it,
Okay.
and look at things. Yeah.
Great,
Yeah.
that sounds great.
Yeah.
So I got diagnosed when I went into grad school in my 20s, and I noticed that my vision was changing, and the prompt to go to the doctor about it because I was increasing my use with computers. Is that part of the stimulus? That wasn't.
It's never been shown that use of computers causes the problem, keratoconus. But I can tell you, when people read and people use computers and people are doing things, they tend not to blink as much, and you tend to get dry eyes. Many times people will have very dry eyes because they're sitting there and they're concentrating and you're not blinking. And so having that discomfort may contribute some. People don't really know why it starts, in the late teens or early 20s. Some people have thought it's hormonal. Some people thought it's activity. I don't know. Do you have any ideas, Dr. Brian? Why it starts in teens or 20s?
This is just my opinion, but I think because that age group, teens and 20s, those people have such high levels of metabolism and metabolic activity that puts more oxidative stress, more free radicals are just in the whole body because they're growing and they have just high metabolism. And I think if there's that, and this is again, I'm just thinking, this is my opinion, I mean, nobody's ever shown this, but I think because you've got already sort of deficient protective mechanisms because of the antioxidant deficiency, but you just rev up those free radicals, that becomes a tipping point, in my opinion.
Yeah. So, but in this day and age, we can't get around computers, but what you can do is take breaks, use artificial tears, blink really frequently, and try and keep your eyes really comfortable.
I've been to a seminar in Irvine and going online at the National
Keratoconus, yes.
Thank you, Foundation.
Yes.
Is there more propensity for the disease to be with females than male?
No. It goes through all races, all in equal distribution in males and females. It hasn't been prone to any one particular group.
Okay, and thank you for that. And I was noticing your chart where you were going with European Americans, Hispanics. I didn't see African Americans up there. Is there like a smaller?
Well, or it could be those were studies done in those countries. So there may not have been a study done in that country. I can tell you in Saudi Arabia, they have very, very high levels of keratoconus. And their theory is it's so dry, it's, with the sand and the dirt, there's constant irritation, there's tons of UV light, and then it also can run in families. So they, in the Middle East, Egypt, Saudi Arabia have very high levels. But I'm not aware of any studies that have been done specifically in Africa population.
And just to add to that too, we get patients, as you may know, all day, every day, from all over the world, every ethnicity, every race, male, female, ages as young as 9 that we've treated, all the way through their late 70s. So it doesn't really follow any specific rules or patterns. Okay. Oh, and also a lot of the same states and countries we see as well. So a lot of the states like Arizona, Colorado, a lot of like drier climates also that we've noticed. So that is very interesting about the Middle Eastern countries.
Hi. I was curious if introduction of riboflavin to the cornea, does that change the production of the degradative enzymes?
You mean right when you do it or long term?
Long term.
I don't know that anybody's looked at the degradative enzymes before treatment and after treatment. I don't know. I could look into that and see if there are any papers out there, because perhaps somebody did it, measuring the tears and the tear film, before treatment and after treatment, but not that I'm aware of. But I could find out, and then I could send the information to Jan, and she can forward it to you.
Thank you.
Any more questions? Yes, a couple. Okay.
Is there like a color, like the eye color, is that one's more pronounced than the other?
No. People have looked, what characteristic does a keratoconus patient have, and there's nothing that says, oh, that puts you at higher risk. No. I think this gentleman.
Thank you. I had a question about supplements for your eyes.
Sure.
There's that some that are on QVC or HSN that Andrew Lesserman's, the Ultimate Eye Support, or and I was taking that for a while. Is there something that we can be taking to actually help us with that?
I don't know that you need something really fancy. I think just the basic antioxidants and that would be useful. I mean, right now, just over the counter, there are a lot of the Ivites, Ocuvite and some of these other ones that have been formulated. Now, they have some things for the healthy of the retina, the lutein and zeaxanthin, but and that's not going to help the cornea, because that is a macular pigment specific for the retina. But the other ones would help, and other antioxidants. I mean, since there's not been any formal study, I am proposing this. This is what I would do based on what I know, but I can't say take resveratrol or not. But there are a lot of antioxidant supplements out there.
That's what we should be focusing on.
Well, I think the antioxidant, yes, I think so.
We also have something at our office that's available. It's only available through a physician office, but we actually sell that at the office as well. It's called Optimal Iron and contains a concoction of antioxidants specialized for the eye. Of course, not that by itself is going to help, but all these different things that both Dr. Kenny and Dr. Bryan have talked about. Even like the UVA protection in your cars. I mean, there's things that we don't really know about until you hear a talk like this. It's not something we're taught to in school, except, brush your teeth, floss your teeth, not, oh, you should wear sunglasses, not because it's bright, but because you can have sun damage, or, take your eye vitamins. Nobody ever says something like that. So I wanted to go ahead and break now. We're a little behind schedule, but thank you so much, Dr. Kenny.
And I
really appreciate it.
You're welcome.
Yay!
I just want to say, unfortunately, I have to go down to Irvine for some of the undergraduate students, but if you do have any other questions, please, you can reach me through Jan, and it's really been terrific to meet all of you.
Thank you. Okay, so we're actually having a battle of the PC versus Mac today, so I can't put my computer and presentation in just yet. But for the people that are online, we're actually going to take a break. We're going to come back at about 1:15, I believe. 1:15, and we're actually going to have Stephen Holcomb, the Olympic gold medalist, that also has keratoconus, to be able to tell his story. So we're really excited about that. So everybody online, make sure you come back at about 1:15. For everybody that is here physically, he's actually going to be signing some copies of his books. Those are free copies of his book that you can keep and actually get him to sign a copy. We even can have you take pictures with him. So that's going to be really exciting. You can also, as soon as you're done with that, go ahead and break for lunch. There is somewhere in the lobby that you can actually eat, or if you prefer to go off-site, that's great too. There's plenty of places to eat around here. So break at 1:15. And also, again, I mentioned Kevin from Oasis is sponsoring this event. Thank you so much for that. His table is outside, and he's actually working for the company that manufactures Intacs. We talked about Intacs as the little tiny plastic segment that's placed into the cornea to help normalize the cone shape, and he's going to have information outside at the table for you. Thanks so much.
There it is. Can you hear me? Hello? Yep. Hello? Can you move it up a little more? Might be too much. Does that work? 1, 2, 3, 4, 5, 6, 7, 8. That's good. Okay.
little bit early. Hope everybody enjoyed their lunch. So just a recap of what the second half of the seminar is going to be about. I'll introduce in just a moment Stephen Holcomb, Q&A, contact lens for keratoconus, which you may be really interested about to know, especially post-operatively. And our lovely Monica Amoris will be speaking. There'll be a Q&A after, little water break, and then Dr. Brian is going to give a very interesting and very informative talk about the differences between the Holcomb C3R and CXL. So if you're not already aware, there are different types of cross-linking, and we will go over that as well as a Q&A at 3:30. All right, so let's start off by going over Stephen Holcomb's, I guess, resume, if you want to call it. He is the most celebrated American bobsledder. He and his team won the gold medal for the U.S. Olympics in 2010 in Vancouver. He won the first Olympic gold medal for the U.S. in the 4-man bobsledding. That happened since 1948. Also, he won 2 Olympic bronze medals for the U.S. in the 2014 Sochi Olympics in the 2-man and the 4-man bobsled. He holds the record for the most medals received in American history for bobsled World Cup, World Championship, and the Olympics. I actually went to Wikipedia, I Wikipedia'd you, and I saw I couldn't believe how many medals he has. So this is just not even like half of his real resume. He's a veteran of the Utah Army National Guard, serving as a combat engineer, in which he earned 6 medals and awards. He is the only Olympic athlete for whom a medical procedure was named, namely Holcomb C3R. So let's please give a warm welcome to Stephen Holcomb.
Oh, there we go. Can you guys hear me okay? Okay. So first and foremost, thank you for having me. This is it's a really good opportunity. I'm excited to be here to kind of share my story. It's been a little while since I've told this story. I wrote a book about it, so I didn't have to keep telling it. No, I'm just kidding. But it is a very elaborate story, and like I said, it's been a while since I've told it in its entirety, so I may jump around a little bit. It gets kind of sporadic and crazy, and I tend to get a little emotional. So I'll try to keep that in check. But I think actually, before we start, I just want to show a little video. Jen's going to cue that up. I'll give you a little explanation of this video. It's what we call a POV, which is a point of view video from the Sochi Olympic track. We took this video. We actually snuck this camera onto my sled. This right here is one of my pushers hiding the camera mounted underneath my sled. It's a lipstick camera. It's about the size of my thumb. It's black and we covered with tape. You couldn't really tell it was there, but we just want to make sure, because if anybody found out that we had this camera on there, A, we would have been disqualified, and B, we would have probably been escorted out of the country. So we were very hesitant to do it, but at the same time, they were not being very fair with the way they were allowing us to see the track, and we needed an advantage. They were allowed to, each Russian bobsledder was allowed 400 to 500 runs down the track. We were only given 40, so we needed to try to level the playing field a little bit. So this is just kind of a fun video for you guys to see that this is kind of what it looks like from my point of view, my perspective, and imagine doing this without being able to see. So hopefully you get. That's me, it's all right.
Holcomb on the track is ready to start. Scoring partner. Внимание, трасса свободна. Attention, focus clear.
Unsuspecting Russians over here. as that sounds, it's exactly what it's like. It really is loud, it's violent. I know a lot of people, we make it look smooth on TV. That ice is really rough, especially during this is like the first or second week the track had been open, so they just didn't know how to do anything with the ice, and they weren't able to shape it well. But yeah, it's about what it looks like. So just wanted to kind of show that video. I had another video queued up, but because of copyright laws, we weren't allowed to show it. It was my Olympic runs. They were kind of cool, but I don't own those videos, so I can't show them. So yeah, that's kind of it. You can shut that down if you want, if you have any cool pictures to show back there, I don't know. But so a little bit about myself. I've been an athlete my entire life. I played every sport you can think of growing up, baseball, football, soccer, basketball. I ran track. But my biggest sport was ski racing, alpine ski racing. I did downhill, Super G, giant slalom. Super G was kind of my specialty. Downhill was fun. I just didn't have the right equipment for that. But it was still a great sport. And I loved it. I did it for about 10 to 12 years. It was amazing. And I don't regret a single moment of it. Why? I was pretty decent at it too. I wasn't the greatest alpine ski racer, but I wasn't that bad either. But at the same time, if you don't make it, it's a lot like these other sports where if you don't make it as a young age, you're probably not going to make it as you get older. So you have to be pretty established young. So I kind of looked for another option, and coincidentally, the U.S. bobsled team was in town training for the 2002 Olympics, for the 1998 Olympics. This is back in 1996, 97 when I started to discover this. And they had an open tryout, I decided I would check it out. I don't know what bobsled's about. This is in my hometown. I'm from Park City, Utah. I should have probably told you that to start with. So there's the Olympic bobsled track for the Salt Lake City Olympics was in my hometown. I actually literally went to a high school called the Park City Winter Sports School, and it was based 100 meters from the bobsled track. So it was turns out it was maybe fate, I don't know. But it was pretty cool. So they ended up, we saw them training all the time. They ended up having an open tryout. I thought I would go check it out. Did pretty well. In terms of ski racing, they have the U.S. national team. The U.S. ski team has the A team, the B team, the C team, and the D team, which is the development team. I actually made it to the D team level. So when I went into the tryouts for the U.S. bobsled team, one of the coaches that was there doing it kind of got me. He said, hey, the numbers that you just put up in this combine, they're really good. You just made the U.S. B team. I was like, sweet. Going from D team skiing to B team bobsled my first day. All right, I'm in. Sold. I'm ready to go. Turns out there's no such thing as the B team. I don't know where he came up with this. I don't know. He knew that I was a ski racer and it would lure me in. I don't know. So I get to Lake Placid, New York for my first camp, and I'm like, they're like, I'm on the B team. And they're like, I don't know what that is. He's like, oh, well, I qualified for the B team. He's like, I really don't know what that is. I was like, okay, well, shoot. So I kind of gave up on that. I ended up doing really well that year. Made the national team, the actual A team, the national team, which was kind of cool. But I was one of the criteria was, in order to make the national team, you have to finish in the National Push Championships, which is just basically a push start on wheels. And basically, the athlete pushes the sled for time, and they rank you by time. And at that time, the team is based on first, second, third place was USA 1, fourth, fifth, and sixth was USA 2, seventh, eighth, and ninth was USA 3. So they said, we're going to take the top 9 athletes. I finished 9th, so I was pretty excited about that. However, I was only 18, and I was considerably smaller than I am now. This is back on my ski racing days when we're more of an aerobic sport. And they said, well, you're a little small and you're a little young, so we're going to go with number 10 guy ahead of you. So that kind of was disappointing. They ended up saying, well, we did tell you top 9, and you finished 9th, so you can stay for the second camp. And I did that, and it was great. And I ended up teaming up with another driver, Travis Bell, who's USA 5, and it was a good little system. One of the guys ended up getting hurt during our national team selection races in October on the ice, and they pretty much said, all right, here's your chance. So within a week of the national team trials, I ended up going to Calgary, Canada, and competing in my first World Cup race, which is the top level of our circuit. And for USA 1, we didn't do very well. I was too small, as they said. The number 1 U.S. sled going into the race was expected to medal. We ended up 17th, I believe. Not because I was small, and like they said, I was not cut out for, but I was just the alternate. So that's kind of where my bobsledding career got started. It's back in 1998, after the Nagano Olympics. So moving forward, there used to be a rule saying that you had to be a bobsledder for 1 year, a pusher, I'm sorry, for 1 year before you can drive. And it's kind of a good rule because there's a lot in the sport that you really need to know, need to learn before you can just go jump in the front of a sled and hurl yourself down. I mean, there's a lot more to it than hopefully as easy as I made that look. It really is kind of challenging. So I knew my chances of going to the Olympic Games in Salt Lake City, in my hometown, in 2002, they're going to take 2 drivers or 7 push athletes. Chances are I'd be a better push athlete, so I stuck with pushing for those next 4 years. Things were okay. I actually made it to the USA 2 team. Brian Scheimer, who's now my coach, he was my driver at the time, and I competed and trained with him for the 2 years leading up to the Salt Lake City Olympics. And unfortunately, because again of my age and my size, 2 weeks or a little over a week before the Olympic trials, he cut me for another athlete that was a 1998 Olympian. So that was a little frustrating, a little heartbreaking. But that was kind of the moment when I realized that I wanted to be a driver from the get-go. I wanted to do this from the start. So I'm going to commit to driving full time now. I'm not going to let them dictate my fate. So I jumped in the driver's seat and I started driving from then on. And it was about that time is when I was first diagnosed with keratoconus. When I first learned of it, it was not, I mean, most people, I had no idea what that was. I was like, okay. The guy's like, yeah, I think you have keratoconus. I'm like, okay, what does that mean? He's like, well, don't worry. And the doctor I saw was like, don't worry about it. It's a progressive disease. It's going to progress. It's going to take 30 to 40 years for you to really see any difference. So you're fine. Your bobsledding career will be good to go. I was like, okay, that's cool. Sure enough, no big deal. My vision was 20/30 roughly at that time. Not a huge deal. I was driving fine. I could see fine. No big deal. And each year, though, my vision was getting a little bit worse and a little bit worse. And kind of going into 2002, 2003, 2004, I was getting a little bit worse and a little bit worse, which comes to find out this is kind of a blessing in disguise, because as I was learning how to drive, I was still learning, I could still see, and as my vision slowly deteriorated, I was more reliant on driving by feel and not so much by visual cues. And turns out the best drivers in the world, I'll drive by feel and not by visual cues. So I was kind of, because of my deteriorating vision, forced into driving by feel. And so I didn't really see it at the time as a benefit. I thought this is terrible. My vision starting to get worse and worse and worse, 2050, 2070, 2080. I skipped 2060 for some reason. Just went right to 2080. And it's just one of those things that I kept it a secret. This is something that I didn't really tell. I didn't tell anybody, because who's going to get in a sled with a guy going blind? That's terrible. It's a terrible idea. And I look back and yes, it was probably a terrible idea. I wouldn't have gotten in the sled myself. But it was just kind of, it was unfortunate it was going to happen. And I started looking for options. I ended up seeing 12 different cornea specialists throughout the next 4 or 5 years. Every single one of them told me the same thing: you're going to have a cornea transplant. And the problem with that is not that I wouldn't have done it, but it was going to take me out of the sport permanently. My eyes would have been too fragile. If I would have crashed with it, my corneas could tear again. Plus the anti-rejection drugs, just a number of problems that wouldn't have made bobsledding possible. So I just kept it a secret and just kept to myself, and eventually maybe go to the Olympics. My goal was to go to the Olympic Games. I missed 2002. My goal was to go to 2006, and that's all. That was my only goal. So we ended up going to 2006. It was pretty cool. Went to Torino, Italy. Sounds like a really cool place. They were not really that thrilled to have the Olympics. Didn't seem like. But it was cool. It was a great race. The first race in the two-man ended up 14th. Just had a bad day. Bad 2 days. But it was my first Olympic race. I mean, I made the Olympic Games. Finishing 14th is pretty awesome. The next week we did the four-man. I ended up finishing 6th, which was the top U.S. sled. All of a sudden, because of that finish in 2006 at the Olympic Games, #1 sled, I became the top-ranked driver in the U.S., and that was pretty cool. So the next season, I came out. At this point, we have an international circuit that we compete on every year. It's called the World Cup Circuit, and it consists of 8 races concluding with a world championship race at the end. And I had never actually won a single one of these World Cup races. I never won a medal. I never got finished first, second, or third. I think I may have had a fourth at some point. I don't know. But I'm going in as the #1 ranked driver, never having won a medal. And so pretty much they said, well, at this point, if you're, you either going into the first race, they said, well, if you don't, do well, then we're not going to support you, and you're going to have to put our money elsewhere. I ended up finishing second, crazy. And then the next race, the week later, we finished second again. And then a week later, we finished second again. And Christmas break happened. We didn't have the funding to go overseas because it's just an off Olympic year. All the funding's going to Summer Olympics. But we're actually sitting #2 ranked in the world, which is pretty impressive. The U.S. bobsledder hasn't been ranked that high in the middle of the season ever. So we're pretty excited about that. We applied for some emergency funding, go to Cortina, Italy, which is pretty much one of the most beautiful places I've ever been in my life. If you ever get a chance to go, highly recommend it. And we go to this race, and we end up winning the 2-man and the 4-man back-to-back. It was pretty incredible. And that momentum pretty much set us on pace to win the overall World Cup, in which we did. We ended up winning the first 2-man World Cup title ever for the United States, 2007. We finished second in 4-man, and then we won the combined overall title. So it was pretty incredible season. It's kind of the point where everybody was like, okay, we didn't really think you were going to do anything. We didn't think you were going to medal. Now you just won the whole thing. Like, that's pretty cool. Like, maybe we'll throw some money at you. All of a sudden, sponsors are starting to get pretty friendly and nice, and the whole federation's coming at me like, here's the next greatest thing that happened to bobsled. Well, unfortunately, because of my keratoconus, my vision's getting worse and worse and worse. I started slipping into a deep depression because I had to withdraw from everything. A lot of what having keratoconus is you can't socialize, you can't be a part of things because you can't see anything. I lived in this 6-foot bubble. It was terrible. People would be like, hey, we're going to watch the game. I'm like, I'm good. Like, I don't watch sports because I couldn't go to the bar and enjoy the game on TV because I couldn't see it. It's just not fun. You gotta go out and do things and socialize with people, and you can't because you just can't see them. And it's frustrating. And so I just kind of withdrew, and I played it off as if I was just like this. Oh, I'm like, no, I'm just really focused and really training hard, and I don't do that stuff. We're focused, and that was totally a lie. But the problem was like that depression started to take over a little bit, and finally just kind of overwhelmed me. And one day, my coach. Pretty much gave to me and said, like, what's going on, man? These guys are busting their butt for you, and you're just not even doing anything. And that's kind of when I came clean. I was like, I can't see. And he's like, well, we'll figure it out. We'll give you some contacts. We'll get you fitted for glasses or something. I was like, it's not quite like that. So I told him, like, yeah, I had this disease, a degenerative eye disease called keratoconus. I've seen 12 specialists. When I started really filling out the story of what it was, he was like, wow, this is not quite what I thought. He said, you know what? We'll find something. Like, there's nothing. You've already tried this. Like, the only option is a cornea transplant. So we looked and looked and looked, and actually we stumbled across Dr. Brian back there, and he was like, hey, I can fix your eyes. I was like, yeah, I bet you can, sure. All 12 other people said they couldn't, but you can? Okay. But I had nothing to lose. I was like, all right, I'm gonna go out to Beverly Hills. I'm gonna see how this procedure works. If it works, I'm back in the game. If not, like, nothing to lose. So we ended up came out here in 2007, I think, summer of 2007. Jen, do you remember? Come on. No, it was, yeah, I think it was late 2007, and it was when I had the first C3R procedure. And it was one of those moments like, if you've had C3R yet, you wake up and you're like, oh, well, it's kind of the same. There's not a whole lot of difference. I was a little disappointed. I was like, well, that's, I was expecting to sit up and be, 20/20 or like have X-ray vision. Didn't quite play out that way, but at the same time, he's like, well, there's a second part to it, but right now, your season's coming up. let's do the second part after the season and see what we can do. So I said, all right, came back after the season ended, did the Visian ICL, and that was the moment when I sat up and realized that all of a sudden it was 2020, and you have this, it's insane. Being able to sit up and like see leaves on trees, who knew? See fibers in people's shirts. It's a whole different world. I mean, it's life in high definition. It's crazy. So that was my first gold medal. Maybe it wasn't technically an actual gold medal, but that was my first gold medal. And actually, almost to the day, 1 year after that, is when we won the first world championship title for the United States in the four-man. Hadn't been done since 1950, 1959 actually, and it was overwhelming. Like that, to win the first world championship title since 1959. Like how many people before me have tried, and I was at this point where I was out of the game a year ago, and now here I am winning the first world championship in 50 years. Almost 2 years to the day is when we won this baby. Now, this is a real deal. Thank you. And it's crazy to think like I was out of the sport. I was done, and I hadn't won too many medals at that point. When Jen put all that stuff up there, that's all post Dr. Bryan. So there's only you can only thank the guy so much. Well, maybe not. You can keep thanking him, I guess. I can. So that's kind of how that went with the gold medal. Sorry, yelling in your faces. And then we've gone on to win more medals than any American ever in the sport. We've gone on to win 2 bronze medals as well in Sochi, which may potentially become silver medals. I don't know if you guys have been paying attention to the news. Thank you. But there's a strange story, and I forgot to mention it while I was getting a little emotional there. So I had the Visian ICL done in March of 2008, and the bobsled season isn't over at that point. So I actually went back to, I don't know if I should tell him this part, because I don't think I was supposed to be doing this, but I actually went back to train, to get back in the sled and start driving. I could see now. I'm like, this is great. I can actually see. How good are we going to be now? I can see. And it was terrible. It was absolutely terrible. It was one of the worst things I've ever done. It was like that. That's terrible. I could actually see what I'm doing. Like, we're going 85 miles an hour. Like, you realize what we're doing? Like, what am I doing? This is crazy. So I had gotten so used to not being able to see really that I'd forgotten what it was like, and it was insane. I remember we came out of one of the corners, we hit the wall, and a piece of ice came off and almost hit me, and I was like, what the hell was that? Like, this happens all the time. Like, what? Really? Okay, this is crazy. And actually, the exact opposite. My driving went downhill quickly because now I was so focused on driving by visual cues. I went back to the way that I wasn't supposed to, and it was really challenging, really hard. People think I'm joking. I actually scratch up my visor a little bit to take away those visual cues because they distract me. That's too much information. I don't want to see all that. So I take it away and go back to what I was good at doing. So that's kind of where that all went. So that's my keratoconus story. Sorry to get a little emotional on you, but if you guys have any questions or they call it Q&A. I don't know if you guys have any answers? Questions, answers?
Have any questions?
Do you wear any contacts now?
I don't, no. I just had the Visian ICL, and that's all I've had since then. And I just realized this, we were just talking about this last night. It's been 9 years, right? 9 years. Yeah, that's crazy. Remember?
How old were you when you had that procedure?
I was 27. I just turned 27. I was almost 28 when I had the second part, the Visian ICL.
I don't really have another question, but I got to tell you, to hear you tell your story and to be able to relate to so many things about your perspective and point of view. And I got all choked up and emotional right there with you, and I just want to thank you.
Thank you very much. It means a lot. Nobody has any questions about bobsledding? You'd be the first people ever.
Do you want to know how?
And you can ask me about keratoconus, but I think he's the guy you want to talk to. That's usually my the other half is people ask me about keratoconus. So I'm kind of like handicapped at the moment.
Oh,
I'm not the expert.
Sorry. I guess it's a keratoconus bobsledding question. It just seems like you must have gotten a massive amount of air in your face as you were trying to do this. Before, where you had the CR3 and the ICL. Were you wearing contacts at that point, trying to get better vision?
Yes. So yes and yes and no to both. The first part, do I get a lot of wind in my face? Yeah, but we do wear motorcycle helmets with visors. I wear what they call a breath guard or a breath deflector, and it keeps from fogging up, so it actually blocks everything from getting to my eyes. That helps considerably. Yeah. And then, what was the second part? Oh yeah, contacts.
Contacts?
I did. I wore contacts for a long time. I had, I never got into the hard lenses. I did have one that was really helpful called Synergize. That was really helpful. It's like putting, huge, like that big. They feel like they're that big. But they worked pretty well. I like those. Those were some of the best. And that was actually, as part of the story now that you remind me, that I didn't really that I haven't spoken about in a long time. That's when things got really rough, is because I was getting contact lenses every 6 months, and then it went to every 3 months, and then every month, and then it was like, I get a new pair of contact lenses, and then 3 weeks later, I'm like, all right, these aren't working. You go back in, and finally, I hit a point, and they said, you don't make them any stronger. Like, that's all you got, sorry. Yeah. And that's kind of, so I was stuck, I was being corrected like 2040, 2050, and then I hit the end, and there's nothing we can give you that's stronger, and it just kind of deteriorated from there, and that's when things kind of hit, really hit the fan, and I was like, I can't continue. And the coach is like, well, we can get you some contacts. I was like, nah, I can't.
Been there, done that.
So Dr. Brian has a question for you, Steve. Are you ready?
No. These are always like complex questions.
First of all, it was just amazing. I've never actually heard you give your story like this in such depth, and it was just unbelievable to have that insight. And on the bobsled point of view, we've talked about this, and you've told me what it's been like being in the bobsled, like you're in a bag of peanuts and somebody's just violently shaking it up. And for the first time, I actually took a ride in a bobsled at Vancouver, about a year ago, and it was exactly like you talked about, just incredibly violent experience. Mm-hmm. When you took your first ride in the bobsled, if you can remember what it was like, can you talk about what you felt and what you were like at the end of that first run, and what kept you going? Because most people would run away. Like, I remember Stephen Colbert, when he took a ride, I think he had to go to therapy afterwards.
He did actually. Yeah, he was petrified. He was really shaken up. That was a good time. And I took Lester Holt down once too. He was entertaining, because you can. I mean, as loud and windy as it is inside the sled, the wind isn't really. It's pretty calm, so you can hear people. And he was very vocal, Lester. I can't really repeat, but it was entertaining. It's one of the few times I've actually laughed while I'm going down the hill. The first ride was it was in Park City, Utah, which is considered to be a relatively easy track, but it's a fast track. And it also has very high G-forces. You reach 85 miles an hour by the exit of corner 6 of 15. And in corner 6 itself, you pull upwards of 6 to 7 Gs. It's not sustained, so it's not like, people are like, I'm not going to pass out. It's not sustained, it's just a short 1 second to get through there. but it's still pretty intense. But I remember, when you're like a tourist or whatever, they kind of set it up. They go from halfway or whatever, and but when you're trying out for the national team, they just basically put you in the sled, kick you off, and you're like, there's no time to figure it out. Like we have a limited time. You got to go out there and bust your butt and try to win these team trials because it's in a week. And you've never done this, you better learn quickly. So I, pushed the sled as hard as I could, jumped in, and my driver was cool. He was like, "Yeah, you can watch the first time just so you can see what's going on." And it was always a joke. The new athletes, like, "I dare you to try to count the corners." And I'm like, "Yeah, I can count the corners." I'm like, "You won't. They never can. You can't, because you're just overwhelmed with what's going on. Your body just can't fathom what's going on." And I remember, like, in the early season, it's still warm out, but the tracks are refrigerated, so they can crank up the refrigeration to keep the ice cold. But the tracks are in sections because it contracts and expands with the temperatures, and so it's not one solid track. It's sections so they can move around. And what happens is the ice melts in between those cracks, and so you get like kind of like you're driving on a bridge or the highway, like so. And I remember we get in going on the first one, like you hear the first one like and like just and like I'm like, this is okay, we're moving pretty good. Like going into corner 4, when you hit corner 4, I was like, wow, that was pretty intense. And it keeps getting faster, and I was like, holy cow, this is getting pretty quick. And you come out of corner 5, and corner 6 is the high G, 6G corner. It's almost a 180, and you're going about 75 miles an hour. And I remember thinking, I thought something, I'm like, oh my God, something's wrong. We're going way too fast. There's no possible way we can go into this corner going this speed. We're going to tip over. Which looks like a wall, like you're just going to hit it and stop. And we went into that corner, and it was the most amazing thing I've ever felt in my life. You just get sucked down and pulled down, and you lose your head. You're trying to like figure out where you're at. Like you can't breathe. Your weight's just pulling you down. And then you come out, and you have less than a second until the next corner. So you're trying to get a breath, and then you're back in the next corner, and you almost nearly suffocate. You're going down the first time because you don't realize the tempo of breathing that you need to do, and it's insane. And I remember, so finally you come out of that corner 6, hit corner 7, and then you go into what's called the labyrinth. It's really, really tiny corners, so you can kind of recover a little bit. And then you go down at 11, 12, 13, which is 2 big, giant corners. 13 is where everybody crashes. But then 14, I mean, you come across the line, and he's yelling at me to pull the brakes, and I'm just like, oh, he's brakes, because the track ends at one point, so you got to stop. So finally, I kind of come to a little bit and pull the brakes, but I was like, holy cow, I'm like, let's do that again. That was pretty cool. Like, all right, and then you do it again, and you're like, oh, maybe it isn't that cool. No, but it's fun. It's addicting. It's an adrenaline rush like you've never felt. People. It's like nothing you can even imagine. I try to explain it like it's like a roller coaster. No, it kind of looks like it, but it's violent, it's fast, it's cold, it's crazy. I like it.
That does sound really crazy, and I'm wondering, right after you had the procedure done, were you advised to wait before you did all of that?
Maybe. Yes. No. I don't know. Yeah, it was a little time. It was longer than, it wasn't like I went out the next day, but it was a couple weeks. I stayed here in town for a couple weeks to make sure that the stitches, everything was fine. So by the time he cleared me to go back. I was just kind of giving him a hard time, but it was intimidating getting in the sled again, just being able to see what was going on. Because again, like I said, I forgot what I was doing. I didn't see it like that anymore. And to be able to be thrown into it again, it was awkward and strange. And it was fun though.
How long were you going through your depression in regards to staying secluded, and what do you think would have been helpful for you during that time to get motivated into contacting Dr. Brian early? And what do you find very helpful for you going forward?
So I was diagnosed in 2001. They didn't really know what was going on, so I can't really tell when I was diagnosed. But it's just something that over time, just because I couldn't be social, I couldn't involve myself, I became secluded and just kind of naturally pull it away, and then you start to realize that, you know, I'm going blind, like it's just terrible. And then you realize all the stuff that I'm going to miss out on, and you realize all the stuff that, you know, I'm starting to become really successful. They're talking about me being the next greatest thing in bobsled, and they have no idea that I'm actually done within months. You know, they don't, and so it's just really hard to deal with the pressure of like sponsors and people investing millions of dollars into me being successful. It was overwhelming. I don't know, you know, unfortunately I was kind of forced to tell somebody about it, and that's kind of what kickstarted things. And I do a lot of work with mental health groups as well, because I went through a severe depression, and it's very strange. It's not something you can just, a lot of my friends, you could tell that I was, like close friends could tell I was depressed and whatnot, and they're always like, hey, just cheer up. I'm like, yeah, just cheer up like that. It's just like that easy, you know? I wish it was that easy. It's just it's a chemical imbalance. It feels good to feel bad, and it was just kind of a downward spiral. And I didn't say this part, it's in the book, but I actually did attempt suicide one time back in 2007. I don't give the details usually because I know the people that were at the event, and I don't want them to feel at all like they were involved. But I basically was at an event, and everybody was just, it was just overwhelming, and I finally just realized maybe, you know, this isn't, I can't face people, I can't face them. I need to, and I had a bunch of sleeping pills, and I downed it with a bunch of whiskey, and I was fortunate I woke up the next day, and it was kind of it was an eye-opener. You know, I was realized like I hit rock bottom, and it was very, very challenging. And I didn't tell a soul. I didn't say anything to anybody until I started writing my book, and working with, I worked with a ghostwriter. I had a bunch of cool stories and stuff, and if I had written the book, it would have been like 50 pages, and it would have been a simple read. But he took my stories and made them longer, and we talked, and we met a lot, and we really got to know each other, and he wrote the entire book, and or what I'm saying, really, he finished everything, compiling everything. He knew there was something else. He's like, there's something else. I was like, no, like, that's my entire story. And one of my teammates, an aerialist skier, aerial jumper, the guys who jump off those big jumps that are crazy. Bobsledding's totally sane. Those guys are not. He actually ended up committing suicide right as I'm finishing my book. And that was kind of the catalyst that was like, okay, I need to come clean. It needs to be more out in the open. So that's kind of why I opened up about that. But it's very challenging, and I wish that, you know, it's very difficult. Like, I wish there was some sort of magical thing you could say or do that would change it. But it's more, it's about talking to people, talk to somebody, and you know, you'd be surprised who can help you. You know, I had no idea who Dr. Brian was. I needed my coach, but we ended up finding a way just through different people. And, you know, my coach knew of a doctor who knew of a doctor who knew of Dr. Brian. And had I not said anything, or he not said anything to me, who knows where I'd be. And so it's just a matter of, you know, it's tough, but just talk to people. And people can help you. You'd be surprised. And you'd be surprised how much they want to help.
What was the reaction of your teammates when they found out about your eyes and keratoconus?
They were not really that happy. Basically, one, because I've been lying to them for a long time, for about 6 or 7 years, 5 or 6 years. So they were not really thrilled. And then, but they knew that I had bad vision. I mean, I wore glasses and contact lens. Like when I took my contacts out, I had Coke bottle glasses, and I did a very good job at hiding that. And I tried to keep it out of the way, and they couldn't tell. But they knew my vision was bad. I tried not to drive anywhere just because it was kind of dangerous. But they knew I had bad vision, but at the same time, they just didn't know to the extent. And so when I told them, I still think they were kind of upset, like, oh, I didn't realize your vision was that bad. But you can't really tell somebody, like, you know, my vision's 21,000. And they're like, okay, like, is that bad? You're like, well, yeah, it's pretty bad. Like, I can't see my hand, but that's cool. And they don't, but you can't replicate that. You can't simulate that for somebody. You know, I tried to tell them, like, it's like opening your eyes underwater. Like, you can tell somebody's there, but I don't know who you are. And I had a bad reputation for a long time because people thought I was a total jerk, because somebody walk in the room, they'd be like, hey, and I'd be like, I'd just stand there. I'm like, okay, thanks, dude. I'm like, what? What did I do? Like, I waved at you. I was like, I had no idea you were even there. People wave. So I had a bad reputation of being a jerk, and it was terrible. But yeah, I don't know. They were okay with it, I guess. Well, let me throw this at you. After, they were very okay with it. Very shortly after. That negated everything. They're like, oh, okay, that's cool. That's cool.
After your book and I guess coming out about your keratoconus, did you have any friends that supported or understood or it clicked what was going on with you? And was there anyone who didn't understand and was discouraging?
Both. There were some people that that understood. Unfortunately, because of the keratoconus, because I was withdrawn and going through that depression, I had, unfortunately ruined a lot of relationships, and I became very isolated, very, very private, and just kind of, I unfortunately ruined a lot of relationships because of it. And when it kind of came out, like my true friends, they understood, and you could tell who your true friends are when they come back and like, oh, I knew something was wrong. I'm like, yeah, but not to the extent. But it was tough. People understood, some people don't. I don't want to name names, but there's still guys on the team that I think do resent me a little bit for the whole thing. It's unfortunate, but it's just, you can't please everybody, I guess.
I'm curious about following the surgery. Did your regimen change as far as doctor's visits? Were you still experiencing halos?
It's hard to say because I didn't really. Once my vision started, the contacts kind of ran out. I didn't really. Who am I going to go to? Like nobody. I'd see a specialist. They say, "Well, get a cornea transplant." I'm like, "Well, I'm bobsledding." And I said, "Well, so there wasn't really a routine." But once I had my other stuff done with Dr. Brian, there became a little. Every year, I'd go out and see him, make sure everything was good to go. As for halos, I don't really have any problems during the day. At nighttime, it kind of gets me a little bit. I have a little bit of halos, but nothing crazy. Not to the point where I'm nervous driving. But then again, I drove without being able to see for a long time. But it's been pretty much smooth sailing since. I mean, it's been absolutely incredible. So.
And your vision hasn't fluctuated?
Not really. It's just got a little. It's gone from originally 2020 to about 25, 2030, but nothing to the point where I'm concerned or worried about it. He seems to be fine with it. So.
Thank you.
I think one of the cool things. Sorry, it keeps going off. One of the cool things I think about the visiting ICL is you can swap it out. I believe, right? Yeah. Okay. I don't want to say something like people are like, really? Oh, and then I get in trouble for making strange claims.
Oh.
You want a mic? We can just give you this one.
I know, I have a lot of questions. What's next for you, and what do you see yourself doing in regards to maybe spreading some more information about keratoconus to athletes or personal wonderful goals?
Well, I'm still bobsledding. The Olympics are in 21 months, so I'm still going for that. I'm actually flying to Tennessee tomorrow to start training. And yeah, we have a World Cup circuit every year. We start that it'll be November this year. But yeah, it just continue the cycle, keep going. The goal is to win double gold in Korea, which is the next Olympics. I'm not sure if you guys are aware of the old doping scandal going on right now. Hopefully getting upgraded to double silver there. But yeah, I'm going to continue doing that. My plan is probably to go through 2019. The World Championships are in Whistler, or back in Vancouver. So it'd be nice to go up there and potentially win the World Championship there again. But outside of that, I don't know yet. I'm kind of just focused on this at the moment, but maybe someday get into, speaking more about it. It's trying to spread awareness about so many different things. I mean, I went through a whole slew of things. Like I said, I speak with a lot of mental health centers and clinics and symposiums similar to this, just to try to get my story out there that there is hope. Don't give up. I did. Look what I would have missed out on. So.
Any other questions? Okay, well, thank you so
Cool.
much, Steve.
Pleasure. Thank you.
We really appreciate it.
Thank you.
You are going to be very interested in this topic. This is contact lens designs for irregular corneas and keratoconus. So we have our staff member and lead contact lens technician, Monica Amores. She's going to give a talk, and there's going to be a Q&A afterwards. So if you can give her a warm welcome.
Hello, everyone. My name's Monica, and I am the contact lens lead technician for Baxter Walkler Vision Institute. And I'll be talking a little bit about contact lens designs for irregular corneas and keratoconus. So some of today's topics that we're going to be talking about will be the lifestyle considerations for each design, benefits from each design, items to overcome from each design, and indications that your fit can be improved. Also, some of the questions that you should ask when finding an optometrist. And we will be going over some study cases. Before I get started, I just want to emphasize that it is important that you do get the keratoconus treated. If not, none of the contact lenses will be successful because the condition will continue to progress. So the prescription will likely change every couple months. So it's also important that you understand that each keratoconus cornea is unique. So no one cornea is similar to another one. Everyone is completely unique and different. Items that affect your fit are definitely your eyelids, your tear level and quality. A lot of keratoconus patients do have allergies, eye allergies. Your pupil size, rigidity of the eye tissue, the shape of the cornea, size, and any previous corneal surgeries. You also have to take under consideration the occupation and hobbies and what you put on or around your eye. And also if you have any pinguicula or pterygiums. So one of the first lenses that we're going to be talking about is the RGP, which stands for rigid gas permeable, which is a rigid lens that aligns on the cornea. Some of the lifestyle considerations are optimal for office environments. So you may struggle a little bit with this lens if dust and wind can cause discomfort with this type of lens. It is also good for normal eye movement. So if you have quick and frequent movements, it is also a good lens, but a very, very well fit needs to be measured for frequent eye movements. This lens is really good for all waking hours. So if you guys need to have the lens for over 12 hours, it's really good for that. And also if you suffer from pinguicula, it's also good for that. benefits of the RGP is if it's a well-fit lens, it is great for dry eye because of the tears are not absorbed. It is one of the least expensive of all custom lenses, and it is easy to insert and remove as well. And it also has a quick manufacturing time for those of you that need to be at work right away after surgery. This is a really good lens to consider. Some of the items to overcome for this lens is obviously awareness of the lens. So we find that most patients adjust to this lens 3 to 6 months. We do try to tell you to blink completely as opposed to partial blinks because it can make the lens constantly pop out. And it is preferable that if you have short fingernails with longer fingernails, it can be a little bit of a challenge to insert and remove the lens. These are some indications if you do have an RGP lens that your fit may need to be improved. If the lens is constantly dislodging frequently, if you have frequent light sensitivity, if you frequently experience stinging or pain, those are some symptoms that you maybe want to go back to your optometrist and say, I continue to experience this, and maybe they can try and modify the prescription to try and improve it a little bit more. The next lens I'm going to be talking about is the piggyback system, which is a RGP that aligns in the soft lens, which is a fit directly in the cornea. The lifestyle considerations are optimal for all cones, designed for mild, moderate, and advanced cases. Where needed is for all waking hours, so it is good for that if you need to wear the lens for a long period of time. And it's also good if you work in dusty work environments, as well as if you have any type of pterygium. Some of the advantages of this lens is you do wear a soft lens that protects the cornea, so it reduces risk of scarring and protects any current scars. And it's also awareness of the RGP is reduced, so it's a little more comfortable than just the RGP by itself. And it does protect the cornea from dust. Items to overcome for this lens is, of course, learning to insert both soft and the RGP. Symptoms need to be very well fit for those with dry eye conditions, and there does need to be 2 types of solutions that need to be used for soft and the RGP. These are some indication that your fit needs to be improved, which is daily dryness with contact lens wear, worsening of glare at night, and if the RGP is dislodging frequently. The next lens that I'll be talking about is the hybrid lens, which is an RGP fused to a soft plastic. The lifestyle considerations are optimal for eyes with a lot of space between eyelids. Physical activity with rapid eye movements. If you only use the 8 to 10 hour wear time per day is needed. So for those of you that need to use this for over 12 hours, this is probably not going to be an option for you. This is recommended for about 8 to 10 hours daily wear time. If one eye has good vision without contact lens while the other eye needs a custom lens, this is actually a very good lens to consider as well. Advantages of this lens: it stays centered over the pupil, mild awareness of the RGP portion, and you adapt to it in about 2 to 4 weeks, and it won't dislodge. Indications that your fit needs to be improved is if you experience pain frequently after removal, if you have frequent light sensitivity, and if you frequently experience stinging or pain. And the other lens is the scleral lens, which is a large RGP contact lens that only touches the sclera. It is for moderate to advanced cones and irregular cones. It's also good if you have dry eyes, because you can insert preservative-free saline into the lens, and upper lids that are drooping. It's also good for large pupils and people that live an active lifestyle. It is a comfortable lens when it is a proper fit. It adapts in about 2 weeks, stays in an eye over pupil with eye movements, and holds preservative-free saline on the cornea. It is a large lens, so it is one of the most challenging lenses to insert. It does require a specific preservative-free saline solution. Sometimes fogging will happen with this lens, so you can remove it and rinse it and reinsert it, and then your vision will be back to how you normally have it. For the ladies that wear makeup, we do recommend that you minimize the makeup around the eye for this type of lens. If not, it can blur the vision. And then some of the indications that the fit needs to be improved is if you have experience with hazy vision within 2 hours, if your eyes are red outside the lens edges, if your eyes are red inside the lens near the cornea, if you're experiencing dryness. And then there's many more lenses, but these are some of the most common ones that work really well for keratoconus patients. This one right here is a soft lens for keratoconus, which again, it's a soft lens that is thicker and stiffer than standard soft lens. Mild cones and corneal irregularities, normal moisture levels for it's both eye and environment. It's recommended for about 10 to 12 hours of daily use. And those who would tolerate mild vision, blur, or fluctuation if comfort is good. Advantages of this lens is less awareness than the RGP and piggyback, unlikely to bind into the eye, and good for occasional wear. Some of the items to overcome for this lens is contact lens needs to stay moist to perform well. Sensation, you'll be aware of the lens 3 to 4 weeks to adapt. Vision will fluctuate more than other custom lenses, and if you do wear makeup, makeup can increase the dryness. Indications that your fit needs to be improved: if your eyes are moderately dry soon after inserting, if you experience light sensitivity during or after lens wear, if lenses feel stuck in the eye upon removal. So the next thing we're going to talk about is questions that you should consider when finding an optometrist. You definitely want to ask things like, does your doctor fit RGPs, piggybacks, hybrids, sclerals, or soft custom lenses? The doctor that should fit all 5 contact lenses designs, you can obtain the best lens for your needs. So definitely ask them if they have these type of options. So in case you're a candidate for any of these lenses, they can at least give it a try, and you can take it from there. Questions to consider as well is, when did your doctor graduate from optometry school? Recent graduates without specialty training will lack experience. Doctors who graduated 25 years plus ago may not be the best option if they do not fit keratoconus patients frequently. How many keratoconic patients does the doctor fit in 1 month? If the doctor doesn't treat advanced cases every month or fit even moderate cases weekly, the doctor may not thoroughly know all the contact lens options for complex cases. Ultimately, skill is built by volume. The next thing I'm going to be talking about is some of our case studies. Now, this patient right here, he's been wearing RGPs prior to having the cross-linking for 48 years. He had the cross-link, the Holcomb C3R with Dr. Bryan. Now, some of his background report, he reported scratchiness, sharp pain, light sensitivity in the left eye with the RGPs worn. Symptoms went from occasional over 1 year period to daily, and now begins wearing now the lens he wears 1 to 6 hours after insertion. RGP in the right eye has no problem. He was examined by 3 different doctors, and all 3 different doctors advised this patient that he needed a corneal transplant, and that was the only option. The RGP wasn't a good fit for this patient because the fit abraded and elevated. He had a corneal scar, so that's why the RGP. This patient should not have been wearing an RGP, and he was wearing RGP for 48 years. So a soft keratoconus lens wouldn't achieve acceptable vision for this patient. His case was too advanced. A hybrid lens, it would be too tight in the corneas. Again, his keratoconus was way too advanced. He preferred the piggyback, so that's the option that we decided to go with. And he would have been a good fit for scleral lenses if he was willing to try it, if the piggyback wouldn't have worked. So he was successfully fit with the piggyback in the left eye and an RGP in the right eye. And his advantages was a soft lens and piggyback system protects the elevated scar. So the lens was very comfortable for this patient. It has comfortable wear and all. So it was for all waking hours, the lens was comfortable. He couldn't feel the piggyback even on windy days before the pain. Before he reported he experienced a lot of pain and discomfort with just the RGP. And a corneal transplant was not necessary in his case because, again, he got the keratoconus treated with the Holcomb C3R, and then Dr. Weiss was able to successfully fit him with a piggyback system in the left eye. Some of his items that he struggled a little bit to overcome was he had to get used to using preservative-free artificial tears 3 times a day. He needed to learn how to insert and remove the soft lenses, and he had to switch to a care system that was good for both soft and hard lenses. This case study number 2 is a 33-year-old post-cross-linking and intacs with Dr. Bryan. Some of the background about this patient was he failed with RGPs due to frequent dislodging and pain. He underwent 2 corneal procedures, the Holcomb C3R and intacs, to normalize the shape. Subsequently, wore piggyback lenses for 3 years, but never fully adapted to the awareness of the lens edge due to the tight upper eyelids. Patient did not want to do an RGP, so he was requesting for a soft keratoconus lens. The rigid portion landed on the region of the cornea with the intacs, and that will cause light sensitivity and pain for the patient. So he was really pushing for a soft keratoconus lens. He did let us know that he would be willing to try the scleral lens system if the soft keratoconus lens would not work for him. He quickly adapted the edge of the contact lens beneath the eyelids. He reported that it was comfortable during all waking hours, easy to insert and remove, and moved to 1 lens per eye. Some of the items that he struggled with a little bit, he had to get used to inserting artificial tears. Night vision is more blurred compared to the RGPs and piggyback. And if lens is dry, vision quality can fluctuate. And our third case study is a 56-year-old post-Holcomb C3R who failed with 4 different lens designs, and again was told by 3 different doctors that the only option was a corneal transplant. Well, he came to Dr. Bryan, and Dr. Bryan, performed the Holcomb C3R, and then he was referred to Dr. Donna Weiss, and he failed in RGPs. He couldn't tolerate the piggyback, and the hybrids, it was just too tight in the cornea, and it would cause him an abrasion. He ended up going to the ER for the lens being a poor fit and too tight to his cornea. And then vision in glasses was poor. He had really poor vision in glasses. And so the RGP didn't work for him because it wasn't centered on the eye. The soft keratoconus lens wouldn't achieve good vision for him. The hybrid lens, it was too tight, and the cone was too advanced for this type of lens. The piggyback system, unfortunately, it won't center in the eye. So the scleral lens was the only option for this patient. The advantages of this particular patient wearing the scleral lens, it was centered over the eye. He got the best vision, so we were able to Dr. Weiss was able to get him with a scleral lens to 20/25 in the left eye and 20/25 in the right eye and 20/40 in the left eye. The lens is safe because it doesn't touch the cornea, and the patient adapted in about 2 weeks. It does hold preservative-free saline solution, and the patient denied any type of dryness. And then the patient did feel safe when driving with this lens because the lens didn't constantly come off. With this particular patient, he did come to the office several times. It took him about four training sessions with me for him to properly learn how to insert and remove the lens. So he was very patient, and so he did understand that it was going to take some time to properly insert and remove this lens because it is a fairly large lens. He did report some fogging after about 8 hours, and we advised him to remove the lens, rinse the lens, and then reinsert the lens with the preservative-free solution. And it took him about 1 month, more or less, for him to insert the lens properly without any type of air bubbles. So, oops, sorry. So that's about it. I mean, this is just, again, some of a brief overview about how contact lenses can help you if they're fit properly.
Okay, there you can hear me. We're actually going to do a Q&A with Monica. So does anybody have any questions? No? Not one person. Okay. So do you have anything to add that you can think about?
No, that was it.
Okay.
You know, just make sure you guys ask questions. That's the most important thing, and just be patient when it comes to fitting lenses. And the most important thing is get the keratoconus treated first and then move on to your options for contact lenses. Okay?
All right, thank you, Monica. Okay, so we're going to take a quick water break. If everybody wants to grab a cup of coffee, tea, there's all kinds of teas, water, snacks. Thank you. By the way, Dr. Bryan is going to be talking about the differences between the different types of cross-linking next, so just want to make sure that you're here for that.
all net. Other talk. It's the other one. It's the other power. Live stream.
So we're going to start a little bit early. Ready there in the back? All right, so please welcome Dr. Brian Boxer-Wackler.
So I want to first of all thank everybody for taking time out of Saturday to come here, and to thank our speakers and Stephen Holcomb, who made the trip all the way from New York, upstate New York, Lake Placid, to be here. So I know I really appreciate Stephen making that journey out here, and everyone else does, and everybody who's watching on live stream too. And I also want to thank my amazing staff who really helped organize this whole event. So I think we also have to give a big shout out to the awesome staff as well. So we're here in the finale, and Eric, who works with us, said, well, okay, you're the last one. Like Kobe says, lights out in the fourth quarter, so I'm going to do my best. And then when we're done, we'll be around for some questions in case anybody has any other questions too. So I wanted to address something that is important, because there are different types of cross-linking. And we're going to talk about the differences and similarities between Holcomb C3R and CXL. And so we're just going to jump right in. So CXL is a procedure that uses a different type of light source for the UV. This is it right up here. And it is a 30-minute treatment as well, so there's some similarities too, and it can strengthen the cornea as well. This company, Avedro, went through their clinical trial with the FDA for CXL, and they got approval in April of this year, and it was based on a one-year study that they did, following patients out to 1 year. And they had also done a study for patients with keratoconus or ectasia after LASIK or PRK, but they did not get the approval for that. It was only for keratoconus. They use a relatively low source of energy in their device, and it has a limited treatment diameter, and we're going to talk about that too. So this is how the CXL procedure works. So as I mentioned earlier with Holcomb C3R, this is non-invasive. Well, with CXL, they have to remove the epithelium in the cornea. Usually it's done like this by scraping, and basically by scraping off the top layer of the cornea, that allows the solution to get access with the riboflavin into the cornea to be able to strengthen with the light treatment. So I want to show you what that process looks like. This is an example of a surgeon scraping off the top of the cornea, basically. Now that is the source of the problems and issues with the CXL procedure, is that scraping part. Because it's invasive, that is what we're going to go through in terms of the research findings of it. And then the light is applied after they have the solution get absorbed to do their strengthening. Now I'm going to be showing data that is not from me. This is actually from the company. So this is the company's data that they actually had submitted, and specifically this is the source of their report that they submitted, and this was in February of 2015 to the Dermatologic and Ophthalmic Drugs Advisory Committee that works very closely with the FDA. So essentially all of the data I'm presenting is from the company's study, their clinical trial. So first I want to draw some attention to one of the graphs, and by the way, I'm always going to be referencing what page of that report this data is coming from. So it's always, in case anybody wants to go look up that report and see this, you'll be able to find this exact graph right there. And when we look on average what their FDA clinical trial results are, they showed that at 1 month in the CXL group that they got an average of 1.6 diopters of cornea flattening, whereas the control group got steeper. Now, I think on the surface that would seem to be like a pretty good result. But one thing that was missing from the graph was the results at 1 month. I'm going to flip back here so you can see starting data reporting on the graph at 3 months, 6 months, and 12 months. But what was missing and not put in was the 1 month data. And the 1 month data is actually in the report, but it shows that there was actually steepening at 1 month. So after that skin layer is scraped off, the cornea is actually measured steeper in the first month, not flatter. So it's almost like there's a sort of a worsening of the keratoconus, and it takes a long time for that epithelium to grow back and smooth out. That's the source of a lot of these issues. So it's interesting because putting it on the graph would have been obvious to everybody that, wow, at 1 month people were on average worse. And it is on page 47 of the report, but it's buried in a very complex chart with numbers that I was able to pull out. So again, we're missing on the graph this 1 month data that I think is very informative to really what the experience of the patient is. It's almost kind of masking it. And it reminds me of this quote by a Scottish poet, Andrew Lang. Quote, "He uses statistics as a drunken man uses lampposts for support rather than illumination." And we're going to go through some other examples of this. But that's the other side of science, right? And these are statistics that we're seeing. And by omitting the 1 month data from the chart is a little bit, reminds me of this situation. So again, when we look at that missing 1 month data, this kind of comes to my mind. Now also the same chart, as I pointed out, it shows that overall there was an average flattening on average of the whole group of 1.6 diopters. Now that sounds like a pretty good result, right? Everybody, yeah, certainly. Well, averages can mask what's really going on. So when we look closer, this is from page 52, we actually see what the progression data is in this group at 1 year for keratoconus. And as it turns out, if you add up, and again, this is the exact chart from the report, if you add up the number of progression groups from 0 to 1 diopter, 1 diopter to 2, and more than 2 diopters of progression, you add all those numbers up, it actually turns out to be over 28% of that group were progressing at 1 year. So in other words, the procedure was not effective at stabilizing the keratoconus. But yet we look back here at this graph, which says on average, we have 1.6 diopters of flattening. So this group, this chart masks the progression data. So they get lost in the averages. What type of statistics are those, right? So averages will mask the important progression rates. And progression rate is really the only way effectiveness can be judged for cross-linking. It doesn't matter the average flattening of 100 people or 200 people. What matters is what percentage of those people kept getting worse, even though they got treated. And this was over 28%. That's the key number. Now, in the press release after the FDA approval, progression rates were missing from this press release. They only reported the average flattening. Now, in the other group that developed keratoconus after LASIK or PRK, when we look again at the progression rate here and we add up those 3 groups, the total progression rate was 37.8%, even higher than the primary keratoconus group. So I'm not sure what the reason was that the procedure wasn't approved for the group that had LASIK and PRK that developed keratoconus afterwards, but was it related to the fact that that group had getting close to a 40% progression rate? I don't know. Well, what I can tell you though is that Holcomb C3R has a progression rate of less than 1%, actually. It's actually 0.7%. 0.7%, so there's a little bit of a typo in that slide, which is the lowest progression rate in the world. Now, the company also concluded in their report on page 116 that the CXL therapy was effective in reversing or stopping disease progression. So I ask you, in your opinion, does a 28% progression rate with keratoconus and a 37% progression rate with ectasia after LASIK and PRK justify that statement, that it was effective? Anybody agree with that, that statement makes sense? Only if you're the one what? Oh, only if you were in the group that got stabilized, you'll agree with that. Okay. Well, the reality is does that statement make any sense? Well, it makes me think of a couple of things, and it particularly makes me think like this.
Things that make you things that make you go things that make you go
Mm-hmm. So why did the FDA approve CXL with a progression rate of 28% for keratoconus? And I don't have the answer. Well, now let's talk about safety. We've been talking about how effective the treatment is. Now let's talk about how safe it is, or the safety aspect of it. So, in an FDA trial, there's trials for drugs and trials for devices, and there's sometimes a combination of trials of both. So I'm going to give you both definitions. Essentially, they define an adverse event for a drug as any untoward medical occurrence associated with the use of the drug in humans. And then for a device, any unanticipated adverse device effect is any serious adverse effect on health or safety. So essentially, it's like side effects or complications in terms of the way, a laid description of what an adverse event is, a side effect or complication. So first, let's take a look at, one aspect of safety is, well, how many people actually lost some vision from it and got worse with their vision? So at 1 month, we see, if we add up these numbers of letters lost, and these correspond to lines on the chart. If you add up those 12.5 plus 9.4 plus 4.2 equals, at 1 month, 26% of people lost some vision from the procedure. Again, it's related to the invasiveness, I believe, of the scraping process of the epithelium, and that's the invasive part of the procedure. Now, the company also said on page 113 that a total of 84.3% of people or subjects in the CXL group compared to the control group, which was 38%, within the first 3 months of treatment had an adverse event or side effect. So, can you imagine that 84% of people had some kind of adverse event? Now at 3 months, where there's some more healing that's gone on, we can see a list at 3 months of the people that had difficulties, ranging from cornea opacities, epithelial defects or abrasions, pain, dry eyes, light sensitivity, blurred vision, tearing, cornea stria or folds, irritation, discomfort, edema, visual impairment, inflammation. It's a big list, including corneal ulcers. And also there was one case after LASIK where epithelium grew actually underneath the cornea flap from this procedure. And remember, the flap is well healed, and still it was able to get underneath and grow. So this is also on the report, page 137, that at 1 year, still ongoing problems in over 41% of people. And this is the list here of all these different issues. So it's a long list. And also, we really haven't even talked about how when the cornea skin or epithelium is scraped off, it's extremely painful in the recovery process for patients. And there's, people may take weeks to months to be able to even get back into their contact lenses that they were wearing. So those are some of the realities of this process. Have any of you had a cornea abrasion? Okay. How painful is that on a scale of 1 to 10? A 12. Yeah, it's pretty bad. So that's what it's like when people are recovering typically from CXL. So the company concluded on page 114, despite this data I just showed you from their own study and their own report, overall CXL performed as a one-time procedure was safe and well tolerated in subjects. Quote unquote. In your opinion, does an 84% of the people with side effects at 1 month and 42% of people with ongoing side effects at 1 year indicate this is a safe procedure? Anyone want to raise their hands? No, I'm not seeing any hands raised. Does that make any sense? What does that make you think? What does it make you go?
Things that make you things that make you go things that make you
Me too. Was the loss of vision statistics reported in their press release? How many of you think it was? Yeah. It wasn't, no. And it wasn't. It wasn't. So, didn't make it into the press release. Well, Holcomb C3R, by the way, all the data I was showing you from CXL, that was just for 1 year. And those progression rates, that's just at 1 year. Holcomb C3R, 13-year track record. It does not need to be FDA approved. It's off-label, just like I talked about earlier, like taking aspirin, off-label use of a pain medicine. So doctors are perfectly fine to be using drugs and devices off-label. It's totally non-invasive. There is no scraping, like I showed you, of epithelium. There's no manipulating, there's no poking or prodding or scratching or traumatizing the epithelium. And we get those drops in the riboflavin because of this proprietary solution that allows it to go through intact. That's the key, intact epithelium, with the typical 1-day recovery back to full functioning. Here's an example of showing the riboflavin in the cornea here with intact epithelium. This patient had intacts. And as we heard from Stephen Holcomb earlier, essentially this procedure has an Olympic gold medal behind it. Along with the 1-day recovery, there's been no loss of vision, no complications. The worst that I've seen is a little scratchiness for that day, and maybe the day after. Just a little scratchiness, and that's about it, just in that short period of time, if anything. And our stability rate, 99.3%, means our progression rate is 0.7%. So I want to have you hear from some people who actually had CXL in one eye and then Holcomb C3R in the other eye.
Hello, my name's Jordan and I'm from London, England. I was diagnosed with keratoconus about 18 months ago and was told in England that all I could do was have a corneal transplant. I actually went to Harley Street in London and I had something called CNX in my right eye, which is corneal cross-linking, and the recovery was very, very painful, and because they didn't offer the Holcomb C3R in England. So I've come here today and I've had the Holcomb C3R, the Intacs and the CK in my left eye and the Intacs in my right eye. Now the Holcomb C3R in my left eye I've had absolutely no pain with after it was done. Just a slight dull ache, but nothing compared to the CNX. The Intacs in my right eye, I've never seen anything sharper in my life. Everything is crystal clear. My left eye was pretty far gone, so even though I still can't visually see brilliantly with my left eye, there's no more double vision. There's one thing now rather than one thing turning into 4 things. So that's also really good. So if you're even thinking about doing this, I really would, because I can finally see again.
Hi, my name's Irfan. I came here to the Dr. Brian Boxler Vision Institute from Manchester. I've suffered with keratoconus since I was diagnosed in approximately 2009. In the UK, I decided to undergo the CXL procedure in my right eye. It was advised to me to do one eye at a time due to the lengthy recovery time. I found with this treatment that there was a very lengthy recovery period. It was very painful. I couldn't put any lens in my whatsoever for the next 4 to 5 months. I also suffered with complications such as like a corneal abrasion I suffered from. So I knew I did have that eye treated. So I didn't want to go through that again with my left eye, which is progressing at a much more advanced rate. So I looked around for different options in the UK, couldn't find anything, and I came across Dr. Boxler here in the United States. I've done a lot of research and came out here, and yesterday I had the Holcomb C3R combined with the Intacs. It was very painless, very quick, I wasn't kept waiting, and I've just had my follow-up appointment today, and I can honestly say that I don't feel any pain whatsoever.
Hi, my name is Dan Sauvé. I am from Harrow, Ontario, Canada. Already had cross-linking done back in Canada to the left eye, which was a tremendous amount of pain. I did the CK in the left eye, Intacs in both eyes, and Holcomb C3R on the right eye. Again, due to the fact I did not want to have the epithelium off procedure again. It was just way too painful. I do plan to come back and see Dr. Brian Boxer-Wackler in the next year or so and have the ICL lens implants. So I look forward to coming back, and I just want to say thank you very much, Dr. Brian Boxer-Wackler, and your staff is just the utmost first class eye care, and I couldn't recommend anybody else other than him. Thank you.
So those are typical experiences when somebody goes through one versus the other. And
Hello, my name's Jordan and I'm from London, England.
I put this little chart together to kind of summarize side by side. And so, you know, in terms of being non-invasive, Holcomb C3R is, CXL is not. Having really no side effects, yes for Holcomb C3R and obviously no for CXL. No pain with C3R, and different experience with CXL. No vision loss, yes, no. Also, we didn't really talk about, but treating both eyes at the same time, that is something that we do routinely with Holcomb C3R, whereas with CXL, typically people need to have both eyes treated separately. And you heard from the previous patients that they had one eye treated at a time and definitely did not want to have CXL again in the other eye. Wait time to put contact lenses back in after the procedure, just 1 day with Holcomb C3R, but it can be weeks to months before people can put a contact lens back in with CXL. Recovery, full recovery by 1 day with Holcomb C3R, weeks to months with CXL, and progression rate 0.7% with Holcomb C3R, 28.4% for CXL. So other limitations in the study is that Intax was never studied with CXL, so there's no data on combining CXL and Intax in that study, whereas we've been doing this for over 10 years, 10 plus years, I should say. And also, there were no treatments on patients with radial keratotomy or RK, whereas Holcomb C3R, we've been doing, helping people with radial keratotomy and their fluctuations and their vision degenerations for many, many years with Holcomb C3R. Now, a note about CXL in children. There were no children, young children in their study. The youngest patient they had was 14 years old. So with Holcomb, our youngest patient is 9 years old. And we definitely know that children have more aggressive keratoconus. So we need to actually use higher energy levels in order to stabilize children. And with the CXL treatment, the light source is the same. It's this relatively low energy level and it's non-changeable. Whereas with Holcomb, the source we use, we can adjust the light, so we can adjust the amount of cross-linking because children need that. So if you have a child, you know, would you want to have your child have a procedure that has, in people older than 14, a 28% progression rate? And if they're even younger, you know, who knows, this might even be higher. And of course, put your child through the pain of that as well. So when we compare progression rates, Holcomb C3R is essentially 40 times or 2,000% more effective than CXL for keratoconus. And Holcomb C3R is 54 times or 2,700% more effective than CXL for progression of ectasia, keratoconus after LASIK and PRK. So what is the reason for this difference? Well, let's talk about that. Well, the answer is that with the Holcomb C3R, number one is we treat the entire cornea diameter. So we go all the way out to the periphery. It's essentially about 157% more surface area than CXL. So here's an example showing, you can see the light source right here, okay? But beyond the light source, this area is untreated. So this is all untreated cornea that doesn't get strengthened, it doesn't get cross-linked. And also another note from the report was that because that epithelium is removed, it can take up to a month for remodeling to take place, and even up to 3 months for the cornea to settle down and stabilize, because that epithelium has to grow back again because it had to get removed in the beginning. Here's an example of a young boy having the procedure, and the light is covering the entire cornea. The other answer to why is the progression rate so low with Holcomb C3R is because we use higher adjustable energy or light levels, and that correlates directly with the amount of cross-linking. So CXL has one fixed energy level, it's relatively low, whereas with ours we go up much higher, multiples of the energy that they're using with that procedure. So we're able to deliver more cross-linking. So there are some other doctors now that are starting to try epi-on cross-linking, and the thing about that is that, number one, that was never evaluated in a formal FDA study, and number two is that they're using the same device that has this low energy level that got FDA approval. So we don't expect there to be any increased amount of progression or stability rates with that, because it's the same device, it's the same limited cornea diameter, and it's not going to be able to treat the entire cornea itself the way Holcomb C3R does. And plus there isn't the follow-up on the epi-on, so at least the epi-on techniques that are starting to be looked at right now and performed probably won't have those side effects from a safety point of view, but I don't expect to see that same improved progression rate, but at least it does make it a safer procedure, but perhaps not as effective as what Holcomb is, because it's the same device, same energy levels. So just to summarize, Holcomb C3R is 30 minutes, it's non-invasive, it's a one-day recovery. We've been doing it since it was invented in 2003. It has a 13-year track record, which is actually the longest history of cross-linking in the world outside of Germany, of any kind of cross-linking. And that's the summary slide, again, comparing the two. So knowing what we know about how it's non-invasive, there's no side effects, no pain, no vision loss. You can treat both eyes at the same time. You can put contacts in the next day. Recovery is 1 day, and progression rate is less than 1% versus CXL, which is painful, has side effects, has vision loss reported, can't treat both eyes. Need to take weeks to months to recover and put contacts in. It has an over 28% progression rate. Is there anyone here that would want to have CXL? Yeah, I'm not seeing any hands up. Well, I thank you for your attention, and again, I appreciate the time that you've taken out of your schedule to come here on Saturday to learn more about all these modern treatments for keratoconus. And again, I just want to give a big shout out to the whole staff for all their help. And again, for Stephen to make the trip out here and be a part of this and share his story with all of you as well. And if you... So if you have any other questions, because we're running a little bit behind, I'm going to just step down and we can talk about that afterwards. So thanks again for coming.
Thank you, everyone. If you haven't already gotten my business card, come find me. If you want to get further information about, I know a lot of people actually had asked me about insurance and costs and things like that. So probably can't get to like every single person, but if you give me your contact info, I can definitely send that to all of you. But we will be out and available for you to speak with, and thank you so much again for coming. It's really exciting to be able to share with other people what we've been doing. So thank you so much.